It's done, Rosano. We are live.
Thanks, Rafael.
Hello, good morning. How are you, Camilo? What a pleasure to see you.
How are you, Alicia? How is everything?
I'm fine. I'm only sorry that we are not there with you in person.
I know it's been a terrible run for us. We're all in our own little corners, but it's always good to see you, even if virtually.
Yeah, I'm so sorry for that, really. No, yo estoy así, claro. No te preocupes. But I'm so glad that you were able to participate. Thank you so much. And I see our colleague from Dominican Republic. How nice to see you, Jose. Thank you for being with us. And whenever you tell wireless, Can you hear me?
We lost you for a while there.
Oh, I'm sorry.
Okay, but your voice is back now.
All right. No, I said that you are the master of ceremonies, my darling.
Yes.
So I am in your hands. We are all in your hands, which is very nice.
Yes. I was told that there were participants still registering, and I was to give them a little time. But maybe we should proceed at this point. I don't know.
You tell us. Maybe you want us to wait a little bit. No problem.
I will make a quick check with the team and see if we're good to go.
Okay.
Okay, I've got the green light. So let's go. Honorable Camilo Gonzalez, Minister of Finance, Economic Planning, and Information Technology. Esteemed Chair of the CDCC. Mr. Alicia Barthena, esteemed Executive Secretary of ECLAC. Honorable Ministers, Chief Medical Officers, and other members of the health and wellness community, colleagues of the UN system and other regional organizations, distinguished panelists, ladies and gentlemen, it is an honor for me to welcome you all to the seminar on non-communicable diseases and their impact on sustainable development in the Caribbean, which I am sure you will all agree is of paramount importance to the welfare of our peoples and the sustainability of our economies at this time. I wish to extend to you all a very special welcome, and particularly to our distinguished representatives from Latin America. I apologize for the lack of interpretation at this session. We would have made a very special arrangement to accommodate you had we anticipated the degree of interest. This is a technical meeting, and so typically held in English. On the eve of our CDCC meeting, this year it will be the monitoring committee of the CDCC that meets. And that's tomorrow. And I want to assure all participants that we will have interpretation into French and Spanish at the meeting of the monitoring committee of the CDCC tomorrow. And the outcome of this seminar is also formally presented to the committee tomorrow. So I hope that you will all find the time to join us and to continue this dialogue on this most pressing development issue. So without further ado, it is my pleasure to give the floor to Executive Secretary Alicia Barcena to formally open the meeting. Alicia, the floor is yours.
Thank you very much, dear Diane, and thank you for to see Camilo Gonzalez is a great honor, and I want to greet you, dear Minister, because you, besides being the Minister of Finance, Economic Planning, and Information Technology of St. Vincent and the Grenadines, you are the chair, the very esteemed chair of the Caribbean Development and Cooperation Committee. Thank you, Camilo, for being with us today, where we are going to discuss a very important matter related to health and to the non-communicable diseases and their impact on sustainable development, and of course, related, of course, as always, with the pandemics. So thank you so much for being with us, dear Minister. I want to greet Diane Quarles and her team, to all of you distinguished ministers and heads of delegations and representatives of the health community. And of course, I'm very happy to see many of our Caribbean colleagues, of course, but also Latin American colleagues joining us today. Ladies and gentlemen, it's a great pleasure for me to participate in this important seminar on non-communicable diseases and their impact on sustainable development in the Caribbean on the eve of the meeting of the Monitoring Committee of the CDCC. As is customary, we use this opportunity each year to put the spotlight on a key development issue demanding urgent strategic and policy intervention in the interest of the governments and the peoples of the sub-region. This year, it should come as no surprise that we are focusing on the health of the Caribbean. And not only does the COVID pandemic continue to rage, but other threats to the physical well-being of the people with the prevalence of the non-communicable lifestyle diseases like hypertension and diabetes in this subregion are exacerbating the impact of each and worsening economic and development challenges. It is well known that the Caribbean is one of the subregions of the world with the highest prevalence of these chronic diseases. In every Caribbean country, more than half of the deaths can be attributed to non-communicable disease. Data from WHO show that non-communicable diseases were the principal cause of deaths ranging from 57% in Haiti to 83% in Barbados. NCDs are also contribute significantly to disabilities. At the global level, among the economically active ages of 25 to 49 years, 7 of the top 10 leading causes of disability adjusted life years in 2019 were precisely NCDs. This number increased to 9 in the age of group of 50 to 74 years. And these statistics have particularly serious implications for the Caribbean. With a rapidly aging population and a high rate of childhood obesity that is currently above 20% among primary and secondary school populations, the proportion of the population that will need care for non-communicable diseases will rise sharply in the next 2 decades, and the future workforce is at greater risk of being far more sick and less productive. The COVID-19 pandemic has aggravated the risk faced by persons with non-communicable diseases. We have observed a shift in the care of patients with non-COVID diseases. And as we reported in the first joint PAHO ECLAC policy brief on COVID-19, there have been postponements and interruptions of care for non-communicable diseases. And we reiterated in this second policy brief that the interruption of essential health services that are unrelated to COVID-19 undermines guaranteed access to health for the population. Meanwhile, persons with non-communicable diseases continue to be at greater risk of experiencing severe illness from COVID infection or even dying. With the proven evidence of the effectiveness of COVID-19 vaccines to prevent deaths and severe illness from the virus, the Caribbean must speed up its vaccination campaign and access to vaccines, by the way, to prevent further deaths and illness and to help build the herd immunity that is required to sufficiently curb further spread of the diseases. Much work is needed and required in the Caribbean when it comes to vaccination against the COVID-19. The current rate of full vaccination in the Caribbean is 35.2% and is lower than the global rate, which is 39%. It's below the rate of Latin America, which is 47.6%. And there is also great heterogeneity between countries. Furthermore, vaccine hesitancy seems to be taking root among subgroups of the population, hindering public health efforts to increase vaccination coverage. Vaccination of the population is crucial to secure a safe reopening of the economies of the Caribbean, especially those countries that depend on tourism to reignite growth, generate jobs, and sustain livelihoods. Therefore, we believe that vaccine hesitancy is not only a public health concern, but a very important challenge to sustainable economic recovery for the subregion. The Caribbean and the entire Latin American and Caribbean region should build on existing strengths to improve the production, distribution, and access to medicine and vaccines. To achieve this, on September 18, ECLAC launched a plan for self-sufficiency in health matters in Latin America and the Caribbean at the 6th CELAC Summit. This is the Community of Latin American and Caribbean States, which was held in Mexico on the 18th of September. And among the lines of actions that this plan is pursuing to achieve is number one, to strengthen mechanisms for pool international procurement of vaccines and essential medicines. Number two, using public procurement mechanisms for medicines to develop regional markets. Number 3, to create consortiums for the development and production of vaccines locally, regionally. Number 4, to implement a regional clinical trial platform in the region. Number 5, to take advantage of the regulatory flexibilities to gain access to intellectual property. And number 6, to strengthen the regulatory convergence and recognition mechanism. All of this has to be based on strengthening primary health systems for equitable distribution of vaccines and universal access to them. We are moving then to design the implementation of this plan with the focal points from throughout the region and CELAC, and I really hope that the Caribbean members will join in. The elevated risks of severe illness and death caused by COVID-19 for persons with non-communicable diseases not only impact health, well-being, and life expectancy, but also a wide-ranging impacts on household and the economy. So these impacts require research and assessment in the Caribbean, and there is a broad scope for economic analysis to drive health interventions and policies which should be explored in depth. This seminar is therefore intended to be a timely and enlightening opportunity to draw attention to those issues and interventions that should be used to shape an agenda towards promoting evidence-based and cost-effective programs and policies for effective management of these NDC epidemics in the Caribbean. COVID-19 has affected significantly the economies of the Caribbean. The Caribbean GDP fell 7.7% in 2020. And in addition to low economic growth and high rates of indebtedness, the sub-region has experienced in the past decade, the sub-region has experienced also climate vulnerability. We know that our heads of state and authorities are now in Glasgow discussing what is going to happen with the agreements of the COP26, and which we will of course talk about this tomorrow during the MONCOM because it's essential for the Caribbean. We estimate in NECLAC that in 2021, the sub-region will grow 4.1%. But the only way to achieve a resilient recovery in a post-pandemic world is to have a healthy and productive workforce. And of course, to have the necessary financing for this. But we really believe that in these circumstances, we believe this seminar will provide us a window of opportunity to address the complicated relationships and interrelationships between non-communicable diseases and COVID-19 from both a health and sustainable development perspective. COVID-19 has shown, even reversed, many of the gains recorded on the Sustainable Development Goals, with non-communicable diseases being predominantly the pre-existing conditions that make COVID-19 infection more severe. The implications of NCD epidemic are far-reaching. By taking an economic approach to the analysis of the non-communicable diseases, we hope that policies that are meant to promote health and prevent diseases will not only be cost-effective, but that they may also be cost-saving, thereby making government health expenditures socially effective. Such analysis will help inform public and private investments in health by establishing the returns on investments. And by doing so, employers will begin to appreciate the benefit of investing in a healthy workforce and its impact on productivity and profit. Schools and ministries of education will begin to see the value of investing in a healthy student population. The economy as a whole stands to benefit from a more cost-effective approach to decision-making in health, and will have implications not only for the health, but also for the national economies as a whole. This is why I'm so pleased to see today a number of eminent panelists that will participate in this seminar. I am accompanied here by the Deputy Executive Secretary of ECLAC, Raul Garcia Buchaca, who has always been so attached to the Caribbean, and he couldn't be absent to this very important encounter. And with you, Diane, and the team, so I hope that, and I look forward very much to the presentations. Thank you again for being with us today. Thank you, dear Chair Camilo, for being with us today.
Thank you very much, Alicia, for framing the very important discussions that we will have this morning. Without further ado, Chairman, Minister of Finance, Economic Planning, and Information Technology, Minister Gonzalez, I give the floor to you.
Thank you very much, Diane, and thank you, Alicia, for your excellent introduction to this meeting. Also members of the panels to come, medical professionals, educational professionals, brothers and sisters from across Latin America and the Caribbean. Thank you very much for joining us in this critical seminar. And Alicia has done such an excellent job in summarizing that I doubt I will detain you for too long before we get to the very important discussions that we have. But it's an interesting time for us to be discussing non-communicable diseases. Many of our ministers and leaders are in Glasgow at the moment, talking about climate change and the future of the region. All of our countries are struggling mightily with the ever-changing challenges of the COVID pandemic. And a reasonable question might be asked, well, why now? Why are we talking about NCDs now? But the truth is that if we're talking development and if we're talking recovery, this is precisely the time that we have to talk about the NCDs. As Alicia indicated, we're all in the midst of a COVID pandemic, and the science is clear that those with underlying conditions are more vulnerable, not only to severe illness, but also death from COVID. And some of the most severe underlying conditions are NCDs. NCDs related to cardiovascular disease, diabetes, obviously respiratory diseases, and cancer are the same underlying factors that have been complicating the lives of Latin America and the Caribbean very much in the midst of this COVID pandemic. And certainly in the case of St. Vincent and the Grenadines, most of the deaths that we have experienced, and that number is unfortunately still climbing, most of the deaths have been related to people who have underlying NCDs that compromise their ability to respond to the virus. Now, NCDs are responsible for 6 of the top 10 leading causes of death in the region. And they represent an ever-growing component of our health spending, and obviously impose very large economic costs on all of the limited budgets of the Caribbean. And in terms of lives lost, and the years of life lost, 70% of that is now due to NCDs. The global average is under 50%. And the developing country average is under 60%, but in the Caribbean, in excess of 80%. In excess of 70%, approaching 80%. And in the Caribbean, people are facing premature death, loss of productivity, primarily due to NCDs. Men in particular are having difficulty in that regard, and a lot of that is related to the gender imbalance in alcohol consumption in the region, which contributes to the NCDs. Poor diet, physical inactivity as our countries begin to urbanize, tobacco use, alcohol abuse are all significant contributors. And I know we have someone from the University of the West Indies on later. Sir Hilary Beckles, the Vice Chancellor of the University of the West Indies, has done some excellent work in highlighting also the legacy of slavery and exploitative colonialism in creating patterns and habits that still resonate today in the form of higher NCDs. The Caribbean has long recognized this as a challenge. We were the first group of governments to have a meeting dedicated to NCDs, and that culminated with a Port of Spain declaration in September of 2007, uniting to stop the epidemic of chronic NCDs. And the momentum from that 2007 meeting led to the Caribbean having a leading role in a meeting at the United Nations General Assembly in September of 2011, I believe, on the NCD pandemic. Now, the challenge is that beyond the declarations, beyond the work that the heads of government have been doing and treaties and UN meetings, the challenge has been that it hasn't translated to effective changes on the ground in the region. NCD is still the leading cause of death and disability. Close to 80% of total deaths related to NCDs. Cardiovascular disease is over 30% of that. Cancer, 17%. Diabetes, also in double digits. And a very useful document prepared by ECLAC this year called Addressing the Adverse Impacts of Non-Communicable Diseases on the Sustainable Development of Caribbean Countries, which I recommend to everyone who has yet to read it, provides some very sobering data that many of the countries in our sub-region are moving in the wrong direction in terms of arresting NCDs, in terms of healthy eating, inactivity, alcohol abuse, and the like. And it shows us that we are going to be far away from our 2030 goals if we don't arrest and reverse the challenges that we have from chronic non-communicable diseases. We know that the cost of NCDs not only affects governments, not only affects health spending, but disproportionately affects the poor. And we have data from the Organization of Eastern Caribbean States that says someone with diabetes is likely to spend in excess of $1,000 US annually taking care of their diabetes. And if you're talking about someone who has an income, average per capita income of between $10,000 and $15,000, $1,000 is significant. And it indicates also that among poor households, the cost of paying for diabetes care is up to 48% of the total income of that household. And so we know that the NCDs disproportionately affect the poor, and that makes it, particularly in this time of increased COVID-related inequality, it makes it an exacerbating factor, and it makes it a critical frontline developmental challenge in the Caribbean. And that's something that I'm happy that we're able to address today. The NCDs, as we know, the tragedy of the NCDs as a developmental challenge, unlike climate change, unlike some of the other exogenous factors that we face, is that it is entirely within the control of our countries. NCDs are preventable, and we can prevent them. It's not something that we have to bemoan or campaign about internationally. We can prevent chronic NCDs from becoming the developmental challenge that they have become. We are the ones who can help reduce the drain on our healthcare budgets, grow our GDP, increase our productivity, because we take some very fundamental steps in addressing the challenge. The current policies, if we go by the ECLAC document, the current policies that are in effect are insufficient because they have not focused sufficiently on prevention. They have not sufficiently synthesized multi-sectoral and coordinated approaches, and they obviously belie the presence of large policy gaps legislatively, environmentally, and socially in having a really effective program to address this challenge. I hope that the seminar we have today is not going to be one where in one shape or the other, panelists and contributors restate in finer detail the issues that Alicia has so eloquently outlined, but that we have a results-based seminar, something that is focused on solutions, something that is focused on credible policy advice and suggestions, something that highlights best practices in the region, so that we can come away from this seminar with a sense, not just that it's a problem, we know that it's a problem, but that there's something we can do about it, and there are real policies, programs, and interventions that can take place at the state and at the community levels to reverse the very troubling trend of NCDs in the Caribbean. And that is where I hope we're going today. And because of that, I will cut short my comments at this point and welcome you all formally to the seminar on non-communicable diseases and their impact on sustainable development in the Caribbean. This challenge calls for sustained efforts to control these diseases and their risk factors, and with NCDs contributing the most to disability-adjusted life years globally, and considering the aging of our population and the high and rising rates of childhood obesity in the Caribbean, NCDs do not merely constitute a health challenge, but they present a formidable obstacle to productivity that could put the future of Caribbean economies in jeopardy. We can all agree that the COVID-19 pandemic has renewed the focus on NCDs and their adverse impacts. We reflect and strategize on optimum measures to stimulate economic recovery post-pandemic. It has become increasingly clear that health and well-being are of tremendous priority. These circumstances foster new opportunities to address NCD prevention and control in a holistic manner and provide a space to re-engage stakeholders on the need to address the challenges of NCDs from an angle of economic sustainability rather than the limited perspective of individual health. Therefore, this very timely seminar is intended to examine those implications for COVID-19 populations like ours with high incidences of NCDs. We want to assess the economic and developmental challenges that prevail and cause these chronic diseases. It is our hope that we use this seminar as an opportunity to exchange views on common interventions that we might implement that respond to both immediate and longer-term needs, and to moderate as far as possible the impact of COVID-19 on our people. We're going to go immediately, Diane, with your permission, into the first panel, and we'll consider this important issue on two panels of experts and practitioners in the field of health and well-being. As the provisional program indicates, the selected topics are intended to promote meaningful dialogue and further action on the evidence-based policy recommendations to address the NCD challenges in the Caribbean. The first panel, which is entitled NCDs and Sustainable Development, the COVID-19 Factor, will examine the impact that COVID-19 is having on NCDs, its risk factors, and on persons living with these chronic conditions. So without any further ado, it's my pleasure to introduce Dr. Simon Anderson, the professor and director of the George Allen Chronic Disease Research Center at the University of West Indies and the Cave Hill campus in Barbados, who will serve as the moderator for this session. Dr. Anderson is the inaugural co-director of the Glasgow Caribbean Center for Development Research and a distinguished graduate of the University of the West Indies. He was a student of epidemiology, biostatistics, and genetics before pursuing his medical degree. Dr. Anderson is an academic cardiologist specializing in heart failure and heart transplantation. He's currently professor of population health sciences and cardiovascular medicine and has significant experience in epidemiological and methodological research focused on chronic non-communicable diseases. I now give the floor to Dr. Anderson and invite him to introduce his panel. You have the floor, sir.
Thank you very much, Honorable Gonzalez, and thank you for the invitation to head this panel. The discussions thus far have been far-reaching and meaningful, and we hope to have very, very keen and deep conversations about what the next step is. Now, I must ask your permission, Chair, to add one person to our panel, Dr. Francis Morey, Deputy Director of Health Services, Belize. We have him alongside Kavita Singh, Fitzroy Henry, and Kenneth George, Barbados, Jamaica, and India. So let me just first introduce Dr. George, who will be our first panelist to speak. Dr. George is graduate of the University of the West Indies with a Bachelor of Medicine and Surgery, and also a Doctor of Medicine in Internal Medicine and a Master of Public Health.
I'm not doing bad as well. I'm okay for the time.
Oh, sorry. He is, prior to his position as Chief Medical Officer of Barbados, he was a Senior Medical Officer of Health for NCD and Elderly Care. His area of specialty include primary health care, public health policy, and program development, including health promotion, leadership, public health, and NCD prevention and control. He has co-authored a number of national reports for Barbados, including the Behavioral Risk Factor Survey 2007, the Health of the Nation Survey 2012, and the Chief Medical Officer's Report 2010 to 2012, as well as the Health Report for Barbados 2016 to 2018. I welcome Dr. George to the floor and ask him to proceed with his presentation.
Thank you so much. It's a pleasure to be here this morning. I am happy that this is a joint effort between ECLAC and PAHO, and that I hope that we have a decisions-oriented meeting. My presentation is going to be on NCDs in the COVID environment, looking at sustainable development. Thank you so much, and let me extend sincere thanks to Ms. Quarles and Dr. Barsino for their opening remarks. Thank you so much. So we can proceed. So we are in a COVID environment, and everyone knows that. Barbados has had its fair share, particularly within the last 6 months. We currently have a curfew from 9 p.m. to 5 a.m. daily. We insist on mandatory wearing of face masks in public spaces. There is currently restrictions in social gatherings and contact sports. We have some restrictions with respect to churches, funerals, and weddings. And we have worked hard to ease restrictions for air and sea travel. Actually, Barbados's airport was never closed during the pandemic. And we hope that within the next 6 months that cruise travel will operate in a safe environment. Unfortunately, there are no face-to-face school-based learning at the moment. We hope that this can be sincerely restarted in January of 2022. We currently institute a work from home policy wherever possible in the public sector. With respect to the Queen Elizabeth Hospital, we have limited or routine surgeries. And currently about 50% of eligible persons who can be vaccinated have been immunized. Next slide, please. So what is the brief situation analysis with respect to NCDs in Barbados? First, we are an aging population. 13% of our population is currently over the age of 65. And this is expected to increase. 70% of adults 40 years and over have at least one NCD, the most common being obesity, hypertension, and diabetes. And 25 and 40% of adults have diabetes and hypertension, respectively. With respect to what is the major causes of sickness and death, heart attack, stroke, and cancers are the leading causes of sickness and death in Barbados. We have approximately 300 amputations a year, which are primarily due to diabetes and its complications and peripheral vascular disease. and we have approximately 300 individuals on chronic hemodialysis. Based on our school health survey done a few years ago, 1/3 of the children in our school-based population are either overweight and or obese. 70% of the Barbados's pharmaceutical budget is spent on NCDs, and 80% of admissions to medical and surgical wards are for NCDs and its complications. So therefore, the challenge is huge and it affects every single individual within our country. It has a significant impact with respect to our future plans. The Barbados National Registry, which was set up as a partnership between the University of the West Indies and the government of Barbados, is operational for over 12 years. And they produce annual reports. And this is just a synopsis of some of the information in the 2019 report. In-hospital case fatalities remains high for heart attacks at 25% and 37% for stroke. The median length of stay for stroke increased from 7 to 8 days within a 2-year period. And the trends for younger men having heart attacks continue to show that the age range is getting lower. So in 2018, it was 75 to 84 age group. And in 2019, the predominance of heart attacks were in the 65 to 74-year-old age group. Next slide. So Barbados did an investment case, and we collaborated with the United Nations Interagency Task Force on NCDs. This was supported by the UNDP and the WHO. And that study has been published. The estimates were, with respect to spending, of 64 million Barbados dollars, or approximately 220 Barbados dollars per capita each year for cardiovascular disease and diabetes alone. And it was further estimated that the economy was losing 145 million Barbados dollars per year due to missed days of work, poor productivity, reduced workforce participation, and the cost of replacing workers who have been afflicted by cardiovascular disease and diabetes. Together, these costs only for diabetes and cardiovascular disease represent 2.6% of the projected GDP in 2015. So what has been the effect of COVID on our current healthcare system? We have had to scale down many routine services and reorganize our healthcare sector. Many of you may know we invested in a new hospital for COVID only, which is at Harrison's Point. It is well executed and has all the modern amenities of a major operational hospital. With respect to primary care, we have had reductions in routine visits and outpatient follow-up. This is a worry to the public health team in Barbados, and we generally feel that there is a reluctance of the population to interact with the healthcare service and healthcare professionals. So individuals will say that the public health systems probably are being overrun by COVID, and there is a reluctance with respect to the population to interact, to receive and access healthcare services. There's an increased use of the private sector with out-of-pocket payment for healthcare services. And persons are presenting later with complications to the Queen Elizabeth Hospital. And this is suspected to be directly related to the scale down of routine primary healthcare services offered through our network of polyclinics. And as you all well know, we have issues with limited vaccine uptake, whether it be hesitancy or persons just opposed to vaccinations. Next slide, please. The at-risk population in Barbados are the elderly, the poor and socially disenfranchised, women and children, and persons with a COVID diagnosis. To date, Barbados has had 167 deaths. Of those deaths, 98% of those individuals have been unvaccinated, and 80 to 85% of persons have comorbidities. The most important comorbidities are hypertension, diabetes, and obesity. So we have what's the current challenges that Barbados is experiencing? And I would imagine this is mirrored in many countries within the sub-region and within the Latin America and the Caribbean on a broader scale. We have limited human resource capacity, and this was prior to COVID and has been aggravated with respect to our COVID response. So therefore, there has been shifting of responsibilities so persons in tertiary care into our Harrison's Point operation. We had redirecting of programmatic funding to support a COVID response, and this is expected. We have the traditional issues of an aging healthcare plan, limited access to new and emerging pharmaceuticals and health technologies. And then we are a healthcare sector and a healthcare system. So we also have to compete with other priority public health interests of our times. For example, climate change and disaster preparedness, the IHR, communicable diseases, and environmental health. What I would say, it is well documented of the linkages between climate change and NCDs. And therefore, I purport that it's not only a COVID pandemic, it is not only an NCD epidemic, but we have the influences of climate change in adding to that, our challenges with respect to healthcare. And there's obviously COVID fatigue. We have been at this for over close to 2 years. We have limited health resources. The same persons are doing the same things. And it is indeed an issue for us. So I have some recommendations of the way forward. And these may be taken for some consideration. We need to strengthen our healthcare systems with a return to primary healthcare as a focus. And although this is indeed difficult, why I say so is that many of our primary healthcare practitioners are now being involved in our vaccination uptake program. And therefore, it is a balance to be struck. We need to invest in community-based programs using minimally trained members of society to enter the workforce to make an impact on the NCD compliance and nutrition. This is a project that is currently underway at the Queen Elizabeth Hospital, where we have identified individuals who are at high risk or have recurrent admissions for NCDs. And these persons are targeted within their communities using minimally trained individuals to assist with nutrition and NCD compliance. Again, we believe that we need expanded use and scope of pharmaceuticals on the National Drug Formulary, particularly for treatment of hypertension and diabetes. Hypertension and diabetes are the intermediate risk factors that are associated with premature death and mortality in Barbados. And we continue to partner with academic institutions, particularly the University of the West Indies, with respect to surveillance and research. And we also have very cordial relationships with CARFA and the Pan American Health Organization. Next slide. I asked for the broader and strategic use of civil society organizations and non-governmental organizations in the delivery of primary healthcare services, including diagnostic services, health promotion, and education. It is important that NGOs such as Heart and Stroke, the Barbados Hypertension and Diabetes Association, and those other key players within our society step up and add value to our healthcare program product. We are currently introducing the Family Nurse Practitioner Program, which, once operational, will support rural primary healthcare services. In Barbados, we are a small island, and we have 3 outpatient services in rural districts, and it is envisioned that the family nurse practitioner can be the leader of the healthcare team, allowing medical practitioners to be used in areas where their support is required. Continuing to engage and lobby governments to support policies and legislation for NCD prevention and control. For example, access to wholesome outdoor spaces for exercise, taxes and availability for alcohol, and obviously there needs to be further movement on the adoption of front of package labeling. Agreed to and enforce school feeding programs through national policies for nutritious foods in schools. We had some help with PAHO in this regard, and this policy has been completed. In Barbados, we have used some unique opportunities with respect to COVID and NCDs. We have partnered with the diaspora in the United Kingdom and United States to increase the numbers and technical capacity of our workforce in Barbados. We have recruited nurses and medical practitioners from Ghana and Cuba. We had over 80 nurses within the last year who came out of Ghana, and we have several persons from healthcare professionals from Cuba who assist with our COVID response. We call for partnerships with the private sector to deliver low-cost primary healthcare services simply because government alone cannot do this. And we are currently partnering with the private sector to deliver COVID vaccines in private offices across Barbados. We continue to collaborate with the Barbados Association of Medical Practitioners in COVID and other health-related matters. And we continue, obviously, to collaborate with PAHO and other regional and international health agencies, which has been our bedrock with respect to how we move forward for COVID. So I hope that this stimulates some discussion. We are all in this together. The solutions are a whole of society approach, not a whole of government approach to managing and responding to the NCD epidemic and the COVID pandemic. I thank you so much.
Thank you, Dr. George, for this very useful presentation. What I take from your presentation is that you speak to sort of like a triumvirate of problems that are afflicting Latin America and the Caribbean: climate change, COVID, and NCDs. It's almost like a triarchy of some sort in terms of the problems that we face. But partnerships, as you outlined, are part of the solution in going forward. So thank you very much. We will take questions and answers through in the discussion section, which we'll invite Dr. St. John to speak. And we'll just move on in our program to our next speaker. Professor Fitzroy Henry has served the Caribbean countries for over 18 years as the director of the CFNI, as it was called, the Caribbean Food and Nutrition Institute. It was a specialized center for PAHO and the World Health Organization. I think I should say that I also worked with Professor Henry back in those days, many years ago. Since obtaining his doctorate from the University of London, he has worked as a researcher, lecturer, author, and consultant on 5 continents, with more than 100 peer-reviewed articles as first author on food and nutrition in illness, wellness, sports, management, food economics, food policy, chronic disease, obesity, and public health. He served as the editor-in-chief for the CFNI's journal Kajanus and its new newsletter Nyam News, and as well as on several national committees. Since joining the University of Technology, Jamaica in 2013, he has developed a unique postgraduate program in public health to train a cadre of leaders to address problems of food security, obesity, and NCDs in this hemisphere. And we work closely together between the University of the West Indies and the University of Technology to deal with these matters. And his training program has attracted several scholarships for talented students across the region. Professor Henry, please, you have the floor, sir. Thank
you. Good morning, Professor, I won't call you Simon, Professor Anderson. Good to link with you again. Honorable Minister Gonzalez, I really appreciate your request for not only the problems and the solutions, and I hope that we can set the stage for that in this seminar. Diane, Alicia, and others, thank you very much for your words of welcome. I wish to thank ECLAC for inviting me to participate in this very important seminar. I want to thank Dr. George for also setting the stage. Even though he was focusing on Barbados, I think we all react and connect with some of the issues that he presented there. What I want to do is to talk a little bit about how nutrition is critical to this COVID NCD link. I want to look at a study done last year in 8 Caribbean countries and looking at how it impacted hunger and nutrition. And then I will present some of the recommendations. But let me start by reminding us about the importance of COVID in relation to chronic diseases. We know that it increases the severity of several of the NCDs and, of course, the deaths that accrue from them because of COVID. That is well known and documented. What we don't often recognize is how, and as Dr. George pointed out just now, how it disrupts the services for NCDs. And that's another impact of COVID. The World Health Organization has done some studies, and they showed that in terms of hypertension management, 52% of the countries that they looked at had that kind of disruption. In diabetes management, 49% of countries. Cancer treatment, 41% of the countries. In cardiovascular emergencies, 31% of the countries. And PAHO also did a study in Latin America and the Caribbean and showed that services to outpatients, NCD outpatient clinics was disrupted by 67%, which is quite astounding in terms of the impact of COVID. We also don't often recognize the reallocation that is done to COVID, and some of that funding reallocation actually comes from NCD's funding. Dr. George also pointed out just now that some of this was in the place in Barbados. And when we look at low-income countries, there were about 12% of countries showing this reallocation. Lower middle income, 18% in upper middle income, and 17% in high income. In the Caribbean, we will be struggling somewhere between the 20 and the 18 because we are considered low middle income and upper middle income. So this is another effect of COVID on NCDs. And then when we think of the impact of COVID on the lockdowns that occur from time to time, in most countries now we have curfews at the night, but some days in the week we also have lockdowns and stay-at-homes. And this, of course, affects physical activity. There's an increase in smoking of tobacco. I won't mention ganja, but smoking of tobacco, which we know are risk factors for NCDs, excessive alcohol that is being taken during these lockdown periods, and of course, unhealthy diets for a whole number of reasons. And here is one I want to drill down a little bit as I introduce my study that I mentioned. So we have the NCDs there, and we well know that there are physiological factors like obesity, blood pressure, glucose, and cholesterol, and there are also behavioral factors. It is well known that nutrition affects most of these and all of these physiological factors. COVID has an impact on the nutrition as well as on hunger, which in turn affects nutrition and affects NCD. So we see that the COVID impact sometimes is not direct, but it operates through several other pathways, but the effect is still certainly there. So the study I did last year was to look at how COVID impacted nutrition and how it impacted hunger. So I just give you a breakdown of the countries that were studied. And there we are in Jamaica. We looked at 2257 households, and you see the breakdown there by country, with Jamaica having the most, 17% of the sample, and St. Vincent and the Grenadines having 9%. All of them had more than 200 households looked at. And when we look at the head of household that were male and female, we see that there was a slight increase, not increase, but a larger percent of male-headed households, 52, and 47.5 female-headed households. The source of income from these countries, putting all the countries together, we see that the salaried workers, civil servants were about 30%, the farmer group about 6%, and unskilled domestic operators, petty traders, 21%, and so on, and a motley of other different sources of income with about 21%. So we had a variety of occupations that we wanted to look at to see the impact of COVID. So let us look at what we found in terms of the impact and coping strategies. In terms of livelihoods, they were about 27%, there was little or no impact. 17% had some impact, moderate 27, and severe 28. So it's the latter two that really are of great concern to us. When we looked at the impact of COVID on household income, we looked at it before the COVID started, and then during COVID around June last year. And we saw there was a reduction of 26% of income. We're moving from about $346 per month to about $255 a month. But let us go down a little bit more and see the differences by categories. When we looked at those in the highest category, which is $125 per week, before COVID, 75% of them were in that category. During COVID, this is June last year, it was 57. So there was a reduction in that high category of 24%. When we look at the lower category, 86 to 125, we see 15.9% were in that category. And during COVID, it increased to 19. Going further down into the poorer bracket, we see that between $45 and $85 a week, 6.5% were in that category before, and during COVID, it increased to 13%. So there's an increase of 6.8% change. And in the lowest category, where we only had about 2.5% earning less than $44 a week, during COVID, that increased to about 17%, making a rise of 14% change. So we see how the lower income group were more severely affected. And the factors related with that severe group, in terms of gender, we see slightly more women than men-headed households. When we look at education, we see primary education more seriously affected than tertiary. Income, we see the different brackets. Again, those in the lower incomes were more severely affected, as we expect. And the independency ratio, this is the total number of persons in the household divided by the number of income earners. So the dependency ratio, again, those that had more than 4 were more affected than those who had 1 to 1. So the coping strategies are 2 main ones. They use up their savings and they borrow from friends, hoping to get it back, of course. But they do borrow from friends, and there are a number of other ways in which they coped. When we looked at the number that were in the moderate and severe category and asked them about price increases in their countries, we see that the price increases were very high for the moderate and severe group when asked, and you see it went up to like 80%. When we looked at the coping strategies at a personal level, we talked about using up savings, and this is just breaking it down by different countries and showing how they used up savings in the different countries in the 8 Caribbean territories that we looked at. Assistance sought by males and female head of households. So we saw assistance sought and assistance received. So a lot of them who sought assistance from various areas, they received assistance. And the value of the assistance, when we look at it in terms of male, those who got assistance for 46%, and the mean quantity, if we quantify the amount of assistance, was $167. In terms of female, it was 54% got assistance, and it was $164. That looks reasonable enough, but here comes the challenge that I want to draw your attention to. When we look at those same households by income, those that earn less than $44 per week, 3.4% got assistance, and it accumulated to about $80. Those in the higher category, more of them got assistance, 11%, and they got more money equivalent. Those in the higher category, 86 to 125, 20% got assistance, and it was even higher. And believe it or not, those that were in the highest income category, 65% of them got assistance, and they got the most, $179 US. When we look at dependency ratio, we see a similar pattern. Those with the low dependence got $203. Those with 2-to-1 ratio had 180, 3-to-1, 160. And those with the highest stress, if you like, the highest dependency, only got 126. So look at the impact of COVID on food, diet, and hunger. When we categorize the food in terms of excellent, good, neutral, not so good, and poor, we saw that 11% said that during COVID it was excellent. 42%. Sorry?
Prof. Henry, I think you're muted, sir. Could you adjust your and unmute yourself?
Hello?
We can hear you now, Prof. Henry. Yes, we can hear you now. Please
You were
continue.
here before, I hope.
Yes, we were, but
Yes,
just for a
please
minute
go ahead.
we lost.
Go ahead.
Right, somebody muted me. I don't have the muting icon here. Anyway, somebody muted me. Okay, so we had about 16% that were not so good and poor. When we looked at the those that changed their the food source, supermarket use was dropped from 49% to 40%. Open market 19 to 16. The community shop increased. People use more of that than the other sources to get their food. And then we looked at the type of food for those severely affected. We see that rice dropped. We're looking at increase and decrease here. And looking across the table, we see that vegetables, there's much decrease in vegetable consumption, a bigger decrease in fruit consumption, even though we have fruits all over the Caribbean. There was a big decrease in chicken, a decrease in fish, and decrease in meat consumption for those severely affected during the crisis. So we also looked at hunger. And we had a little index which we created by worrying about food running out, skipping or cutting meals, and going without food all day. So those that had that never happened is 0. 1 to 2 times during the crisis, almost weekly and almost every day. So we created an index where we said no hunger would be 0, mild hunger with those with 1, moderate those with 2, and severe those with 3 or 4. So we created the index and we look at the severity of hunger. So we found 60% said there was no hunger problem during June last year. 23% there was mild hunger, 9% say there was moderate hunger, and 8% say it was severe hunger. 9 and 8, 17% said that there was moderate to severe hunger. And the factors relating to it are the similar factors that said they had severe effects, where education in the categories that we expect, where the lower categories or the disadvantaged categories suffered from severe, moderate to severe hunger. So finally, we looked at also the recovery and the help that they may need. So in the different countries, there are those that said, well, we don't have any challenges. I think we can cope despite the COVID problem. And then the next category is those that said, yes, they need assistance, and the time to recover would be about 3 to 6 months. And this is this group with, and you see the breakdown there from Antigua going opposite into Guyana. And those that said, yes, more than 6 months they will take to, more than 6 months they will take to recover. Now, that was June last year. This is what? This is, we're in November. the year later. So we don't know how many of them actually recovered. It would be, we'd love to know if in fact what they projected is in fact true. And then the type of support required, those that need, according to income, those that needed money or job related, food, farm and food price related, and those who just said, let's just reopen the country and they need government assistance. So we see the categorization according to the 3 income categories there. Interestingly, you know, many of them required a lot of farm assistance. So the key findings from this study, Mr. Chairman, are 1, 30% of the households said impact was moderate to severe. The mean household income fell by 26% from $346 US to $255 per month. 62% used up savings and 21% borrowed. 30% sought official assistance and 29% received assistance. And there was an inverse relationship between need for support and the receipt of support. 40% experienced some form of hunger, and 42% said it was moderate to severe. In 16%, the diet was not good or poor. Those who were severely affected had a decreased intake of fruits, vegetables, fish, chicken, and meats. For 20%, it will take more than 6 months to reach pre-crisis food security status. As I said, I hope that they have reached that level, but given what has transpired since last year, one doubts it. 45% wanted jobs or income, 28% wanted farm support, and 18% just wanted the country to open up. So when I look at the conceptual framework that I had there, we see that hunger and nutrition is very much related to NCDs. And the key recommendations is that we have to look at food security risk mapping to identify the areas that we know will be affected by not only this pandemic, the next pandemic, and of course the usual things like hurricanes and floods. We have to fix the allocation problem to ensure that the most needy are the ones that are served. We saw that inverse relationship. Farm support and farmers markets will bring down prices. The assistance that we give must be nutrition sensitive so that we can protect the risk or the specter of NCDs, even though we are trying to solve the problem of COVID. Our food systems need to be more resilient for the future crisis, and we need to do follow-up surveys to determine the risk of NCDs at the household level. And I just want to acknowledge the FAN project, the ICD FAN project, and the UTEC, my university, for the support. I want to thank the 2,257 households across the 8 countries that during crisis, they actually stood by and answered our questions. And these are the colleagues who helped me to do the study in the 8 countries. And I end there.
Thank you, Professor Henry. This was really an interesting presentation about household index, household hunger, and of course the disparities that you see very clearly. We'll move on now to our third speaker. This is Dr. Kavita Singh. Dr. Singh is going to speak on psychological dimensions of dealing with NCDs during COVID-19. Senior research scientist in Public Health Foundation of India and an adjunct faculty at the Herbert Department of Global Health in Emory University in the US. Dr. Singh is an epidemiologist by training and has interest in global cardiovascular health epidemiology, clinical trials, implementation science, health systems, and policy research, and who works across a spectrum of CVD prevention in research on implementation and evaluation of quality improvement strategies, the interaction between COVID-19 and cardiovascular diseases, and of course the economic impacts of COVID-19 on chronic diseases. In 2019, she received Dr. Singh received the NIH Emerging Global Leader Award to conduct a study that aims to develop and test the feasibility effectiveness of a collaborative quality improvement strategy for secondary prevention of cardiovascular diseases in India. Dr. Singh, please continue with your.
Very much, Dr. Anderson, for your kind words. Let me share my screen. Please, can you let me know
So
if you
we
can
can see your screen if you switch it to presentation mode. Perfect. Perfect. Go ahead.
Yeah. Okay. So thank you very much for this opportunity to present in this prestigious seminar. It is indeed my pleasure, and I feel honored to be part of this United Nations United Nations ICLAC seminar. So I'll begin with my talk. So in this presentation, I'll be, can I just a minute? Yeah. So in this talk today, I'll be speaking about the impact of COVID-19 pandemic on chronic conditions and the changing environment that's been taking place since the beginning of the COVID-19 pandemic, particularly for healthcare delivery, and the potential role of digital health innovations to reduce inequalities in chronic disease care. Then what are the gaps in COVID-19 research? And I would be presenting some preliminary findings from the World Heart Federation COVID-19 and cardiovascular disease study and make some concluding remarks at the end. Okay, so we all know that since the beginning of the COVID-19 pandemic, this pandemic has imposed and is presented an unprecedented challenge to the healthcare communities worldwide. During the first wave, we witnessed huge shortages in healthcare services due to the acute COVID morbidity and mortality, when the healthcare providers were not very sure about the treatment or the management plan and how to deal with COVID-19 cases. And this continued during the second wave, where we saw there were deferred or delayed treatment due to delayed treatment particularly for people with chronic conditions. And it continued further during the third wave that we witnessed in several countries, where there were still interrupted outpatient services or preventive care due to the either mobility restrictions or the lockdowns that were imposed to contain the spread of the infection. A general practitioner from London was quoted in the New York Times that we're basically witnessing 10 years of change, the subclinical changes in patients with cardiovascular diseases who were infected with COVID-19. So you can imagine that within a week, patients with chronic conditions, particularly cardiovascular diseases, they had severe consequences, and in the form of myocarditis or in form of heart failure or mortality. So there were several conditions due to the COVID-19 infection, not just the infection, but also the pandemic, because of the associated mobility restrictions or the strict lockdowns that were imposed in several countries. And that this imposes several risks for people with chronic diseases, and particularly those with cardiovascular diseases or those at higher risk for CV cardiovascular disease. This is primarily due to the traditional ambulatory care that was disrupted because the focus was on dealing with COVID-19 cases. And therefore, many patients with chronic conditions like CVD, they had their delayed care. They had delayed either in lab testing or visit to the clinic, including preventive care. Also, the COVID-19 pandemic during the first wave also impacted the supply of medications and pharmaceuticals, which resulted in new impediments to medication access, like difficulty in access to not only care, but also medications, which further impacted on adherence to prescribed therapy. In addition to the clinical issues that were surrounded around the COVID-19 pandemics, it also stress and anxiety from the fear of COVID-19. And all of this can affect the long-term consequences in people with chronic conditions. So in the next few slides, I'll be presenting the data or results from a mixed methods evaluation that we conducted in India. So we all now know that people with chronic conditions are prone to be affected by the COVID-19 pandemic. And when we did the study, there were limited data documenting the impacts, particularly in low and middle income countries such as India. In India, just to let you know that on 24th March, the Indian government ordered a nationwide lockdown, and very little time was given to prepare for in response to this lockdown. And this lockdown continued until June in 4 phases, and further it was extended in containment zones that had high cases of COVID-19. So the primary objective of the study was to assess the impact of COVID-19 and the related mobility restrictions on access to healthcare, also the impact on employment and household income. And we also compared the consequences in rural versus urban communities in India. So to answer these questions, we conducted a cross-sectional survey in 4 different states. The survey was built into existing large cohorts that's currently ongoing. These are called CARS and ODED cohorts. We did a telephonic survey amongst individuals with 1 or more chronic conditions like diabetes, hypertension, heart disease, stroke, and chronic kidney disease. The data were collected between July and September last year across the 4 states or sites in India. So now presenting the results. The results are published earlier this year in BMC Public Health. So in this survey, 1,734 participants completed the survey and the response rate was 74%. The mean age of the participants was 58 years and nearly half were men. So in this figure, I'm presenting the comparison between rural and urban communities, and the urban communities or the participants is highlighted by orange bar, and the rural participants represent the blue bar. So although when the survey was conducted last year in July, we see that there were more number of cases of COVID-19 in urban communities. However, it was the rural participants, almost 86%, who experienced fear or stigma related to COVID-19. Very surprisingly, almost 95% of participants from rural communities, they experienced difficulty in accessing healthcare. And there was also a sizable proportion among urban participants, 75%, who faced difficulty in accessing healthcare. Then almost 1/3, 37% of rural participants faced difficulty in access to medicines due to COVID-19 situation. Around 19% or 20% participants also faced or had worsened diabetes or hypertension symptoms. Very interestingly, and this is similar to the data presented by Dr. Henry in the previous talk, rural participants also reported reduced fruits and vegetable intake during the COVID-19 situation. However, urban participants were not that much affected. About 1/3 of participants experienced loss of job, almost similar both in urban and rural communities. And 2/3 of participants experienced loss of income, slightly higher in the rural communities compared to urban communities. In terms of functioning of local health facility during the COVID-19 situation, between 60 to 70% participants reported that the healthcare facility, like the primary healthcare center or district hospitals, were functioning. However, the treatment satisfaction rate during the COVID-19 period was really poor. It was just 4% amongst the rural participants, which was somewhat higher amongst the urban participants, around 24%. So we then looked into the predictors or the factors associated with difficulty in accessing medicines by running a multivariable logistic regression model. And here you can clearly see that participants from rural communities, those with chronic conditions like diabetes, hypertension, and those who experienced loss of income were at a higher odds of facing difficulty in accessing medicines. On the contrary, on the other side, participants who reported receiving financial support from government, like during the COVID-19 pandemic, in some states, selected states in India, they provided some financial support to overcome the challenges that they were facing during the pandemic. And it did provide some protective effect in terms of accessing medicine. So it was proven to be beneficial. We then looked at the correlates or factors associated with worsening of diabetes or hypertension symptoms in the survey participants. And not surprisingly, people with diabetes who had diabetes or hypertension faced more worsening symptoms, which is a circular argument. But other than that, those who also faced difficulty in accessing medicines experienced worsened symptoms of diabetes or hypertension. Here, interestingly, again, those who received financial support and those who experienced loss of job, they also experienced worsening of diabetes or hypertension symptoms. This indicated that the financial support provided by the government may be sufficient to overcome the challenges in terms of accessing medicines, but not worsening of diabetes or hypertension symptoms, because the amount that was provided by the government was really small. It was around $20 US. So as part of the study, as I mentioned, it was a mixed methods evaluation. So in addition to the quantitative survey, we also conducted qualitative study to describe the challenges posed by the COVID-19 pandemic in people with chronic conditions and to understand their experiences that they have had during the lockdowns or the mobility restrictions and what could be the mitigation factors. So to conduct the qualitative study, we carried out in-depth interviews with 40 patients, and these were audio recorded, transcribed, and coded using a software called MaxQDA. We performed thematic analysis using interpretative approach. So these are the major themes that emerged from the qualitative interviews and the challenges that were faced by the participants. The first one was the financial difficulties that most participants faced, and they also experienced difficulties in continuing their regular business or either they lost jobs. You know, in patients' own word, they mentioned or they described that, sorry. Yeah, the impact was that there were a lot of problems. We took the ration distributed by the government. We consumed that. There were a few things at home. We sold 1 or 2 things with the help of my daughter. My son drives a rickshaw and my husband stays at home. We are old. It impacted him. He was out of work for 3 months. This was the 3 months when there was strict lockdown imposed in India. Then many participants also reported difficulties in getting back to their work due to lack of transportation, as explained by one participant, that I'm a driver. Before lockdown, I went home for some work, and because of lockdown, I had to stay at home for 2.5 months. My wife, children, and I are jobless since then, and there was no possibility of doing any work or going anywhere. We had a lot of trouble at that time. Then patients also faced difficulties in accessing inpatient services and access to treatment because there was a reallocation of healthcare facilities and care providers to manage COVID-19 during the first 2 waves that we experienced in India. And one patient mentioned that I was not keeping well and none of the hospitals were taking any admission. They said that due to COVID, beds are not available. And if you're ready to sleep on the ground, then we will take your admission. So the situation was really grim, and particularly during the second wave that we experienced in India. Also, due to the pandemic, a lot of participants delayed testing of their blood sugars that requires, particularly for diabetes patients, for regular monitoring or their clinic visits due to the fear or anxiety that was associated with COVID-19. Like one patient described that I was scared that I may not have the corona infection, but because of someone else, I may get affected. Sorry. So we have doubt to visit to the hospital or to doctor, and I didn't want to get infected by this. So in terms of mitigators, we we came to know during these interviews that a lot of participants with diabetes and hypertension were mostly aware of their elevated risk of poor outcomes or consequences if they get infected with COVID-19. And therefore, many of them fear to go out either for regular exercise or walk. Almost all the participants were very well informed of preventive measures like wearing masks, social distancing, or washing hands. But very few participants actually reported use of teleconsultations with their doctors, and they actually delayed their regular clinic visit or any procedures if it was scheduled. One participant mentioned that we have to be careful from the corona and we have to be safe from this, and that's the only medicine now. This was before the vaccines came into picture. So the key messages that we learned from the study was, number one, the COVID-19 pandemic had unforeseen adverse impacts on health, access to treatment, care goals, and employment. Rural participants disproportionately were affected. They had poor treatment to healthcare access and also poor treatment satisfaction. And they also reported reduced fruits and vegetable intake. Clearly, the pandemic impact extends beyond health as it severely affected household income, livelihood, coping skills, as well as interpersonal relations due to social distancing and other measures. This pandemic exposed several management difficulties in the health system, but I believe it also provides some opportunities to close those gaps with innovations in the new post-COVID India. So with the changing environment for chronic disease care with the wake of COVID-19, we are seeing a faster adoption of telemedicine, use of remote consultations, mHealth tools across worldwide. And to support this, even government is implementing some reimbursement measures to adjust for this digital transformation. And clearly, the digital health interventions like telemedicine, mobile health, and decision support, they have the potential to reach out to hard-to-reach populations and across race and ethnicity, particularly the minority populations. Thereby, they can improve the outcomes by improving access to healthcare, utilization, and also quality of care. This was an example from India where we had recently launched an assisted telemedicine clinic where we have trained a primary healthcare worker to provide care using a telemedicine unit where specialist consultations are done through the assisted telemedicine unit. And within the first month of the launch of this telemedicine clinic, over 800 consultations have been done so far. This is an interesting bibliometric analysis that we had conducted early this year. So we looked into the research that's been published across the world using WHO COVID-19 research database. And not surprisingly, more than 95% of research on COVID-19 has been published or is being conducted in Europe, North America, and Western Pacific region, and less than 1 to 2% in Southeast Asia region or Latin America, and less than 1% in Africa or Eastern Mediterranean region. So to bridge this research gap in terms of understanding the trends or consequences of COVID-19 pandemic across the world, particularly from the underrepresented countries, the World Heart Federation is conducting a global study to identify cardiovascular risk factors and outcomes in patients with COVID-19. It's an observational cohort study of consecutive confirmed adult COVID-19 patients, and we have recruited more than 5,000 patients from 40 hospitals across 23 countries. The preliminary results from this study was presented at the European Society of Cardiology late-breaking science, and these are the key findings.
To say, running out of time.
Sure, yeah. So the major comorbidities that we saw was hypertension and diabetes, and the in-hospital deaths were 14%, and up to 30 days, the overall death was 17% in this cohort. So we believe the findings from this study will further help in understanding the impact of pandemic and guide the healthcare planning globally. This is my last slide, and I've already mentioned some of these points that the pandemic had unintended consequences on the healthcare access, psychosocial, and economic status of the population, and it also opens new opportunities to revolutionize patients' access to treatment by using either telemedicine or home monitoring device or home delivery of medicines. Thank you very much, and sorry if I've exceeded.
Thank you very much, Dr. Singh. Don't worry about it. I'm the moderator. It's my fault for letting people run over time. We'll just move into our last presentation by Dr. Francis Maury, who graduated from the Cuban Medical School in 2002 and has worked for more than 10 years in the Western Region Hospital in the capital city of Belmopan for about 9 years. Then took up the role of National TB Coordinator in 2009 to present. Dr. Maury, please begin your presentation. We will get remarks from Dr. St. John afterwards. We are now in the discussion segment of the period, so may I ask you to please restrict your time to the 15 minutes. Thank you.
Yes, good morning. Could the load up the presentation? Yes, good morning. I send the presentation. Do you have it? It's not allowing me to load.
1 second, please.
Whilst we get that loaded, we just wanted to remind colleagues that please put some comments or questions in the chat. I will monitor this, and during the discussion section, we will bring some of these questions or comments to the floor. Thank you very much.
Okay, meanwhile it gets loads, I believe I can start from my end here. Sorry. For those, Belize is a small country located in Central America with a population estimate of 430,000, which is the media estimate for 2021, with an approximate 8,867 square miles, 6 districts, 4 health regions, the only English-speaking country in Central America with a multi-ethnic population that includes Creole, Mestizo, Garifuna, Maya, East Indians, Mennonites, Chinese, Taiwanese, and other individuals from Central America. We've had a population shift within the last 30 years, and which to now currently we have a large population that is within the age group of 15 to 49. And this by itself, I'm signaling it because it's not a healthy population, and primarily because it's where we have the diabetic population, the young hypertensive population, the obesity, those who are currently suffering from kidney disease, persons who have HIV/AIDS, persons who are developing cancer at the early onset of adulthood, persons who have tuberculosis and other infectious disease of concern. In the beginning, how we started COVID, we have, for example, in the districts, we have a large number of NCDs, primarily in the Belize district, which with 33% of NCDs. Belize we don't have a per se exact population of persons suffering from these diseases, for example, high blood pressure and diabetes, because the continuous lack of information within Belize healthcare information system and the entering of data has not been able to provide such data. Nonetheless, the number of persons who are passing away from the 3 primary NCDs of concern for us are hypertension, diabetes, and kidney failure, which presents itself in the 3 most affected districts of the Belize district, which is the most populated one, having approximately 120 to 140,000 people within that particular district. The district of the north, which is the Orange Walk and Corozal, are areas of concern for us where the pandemic started, and therefore the highest amount of deaths were seen within the first 3 years. It's about slide 5. If you can pass to slide 5. 5. Okay, that's that one. And particularly the context of this is where the pandemic started. This is where he hit us the hardest. And also this is where the current trend of NCDs previous to COVID, this is how it has affected the country. Next slide. How did we go into this? Again, this is a slide I believe that was shared with us by Dr. Lafia Samuels, where we know that the amount of persons who suffer from diabetes, we only have 29% of those who are controlled. Now, this is 2018, 2019 data. In regards to hypertension, we are talking about 11.3% of our population that are non-hypertensive are currently under control. And so when you're going to a pandemic, which the major disease of concern, and where most of our patients are dying, or our population are dying, and if you have a high population of which you have almost 61% of that population, or 89% of those who are completely under control, who don't know their numbers, who don't have a regular diet, is a concern, and hence we believe the large number of deaths that are being seen in this particular population. Next slide. The 2018-2019 study that was supported by Taiwan ICDF, and this is particularly of interest because we're talking about a population of citizens within the 20 to 25 age group who have the highest prevalence of suffering from kidney disease, 13.9. I believe the global trend is somewhere close to 15. We're talking about the higher prevalence in the female population compared to the male population. We're talking about kidney disease being more particularly highest prevalence in the ages of 50 to 55. We're talking about an ethnic group that is the mestizo population in the north, who are mostly obese. Their females are obese. They have short stature, having a high prevalence of 15.5%. And so, with part of this particular ethnicity is where the pandemic, the first wave of the pandemic started, and the second wave where we were hardest hit. Persons who were presenting to our clinics and facilities with sudden death, persons who were pre-Delta COVID strain, dying in their homes, coming to our facilities and getting complicated with severe COVID, or critically and becoming critically ill within 48 to 72 hours, presenting multi-organ dysfunction, kidney failure, liver failure, respiratory compromise, and passing away only within 72 hours. We're talking about the lifestyle behavior. These persons, they consume a lot of alcohol because it's very cheap. They consume a lot of sugar sweetened beverages, particularly because of they're neighboring to Mexico, the border, and there's a continuous scenario of contraband of these goods across into Belize. And so that particular community, or these particular communities in the Northern District, are where the pandemic had hit us the hardest within the second wave. Females being obese, and also within that particular group of concern, we're talking about unemployment, we're talking about a poverty rate of more than 44, we're talking about an obesity and overweight of more than 60% within that particular Belizean population. Next slide. As regards to cancer, the five most frequent cancer have been affected us pre-COVID were the breast, cervix, prostate, and head and neck, and in particular other cancers of concern with it 15%. Next slide. So coming into as we a brief snapshot of what we saw in 2020. This is a Belizean context of how we saw that there was a complete shift in regards to the deaths seen in both male and female. There was the traditional disease of the heart, malignant neoplasm, diabetes, cerebrovascular disease, HIV, and hypertension, and other diseases of concern. You saw a shift. So COVID has made its mark. It has made an impact on the health of our people. It has displaced all known entities in regards to the percent of death it has produced. So it's within that particular year of 2020 of March, when we started seeing late March, when we saw our first case of COVID, to December 31st, there were almost 324 deaths in Belize. So it displaced everything, and it by itself took up the second part of the 10 most frequent causes of death in the country. Next slide. The current status for COVID, we're now in our third wave, and as my colleagues, Dr. Jared said, we've gone through all the public health measures of state of emergencies. We've gone into lockdown, we've gone into a curfew, and all depending on the current context of the outbreaks in the communities and in the particular towns and villages. And so we are now into our third wave. We've gone back into some sort of normalcy, yet we still have a long way to go. And it seems as though the biggest challenge is the change in behavior of the general population, the change in behavior of the of a person and his attitude towards how we can all contribute as a community and as a people and as a country to control the continuous community transmission within Belize. We've not been able to pinpoint, or no country, I think, has been able to pinpoint the exact measure that has triggered a sudden decrease in the outbreak. I mean, when we first saw our case in March of last year, we went into a state of emergency. We successfully had about approximately 50 to 55 days. We did not have any case. When we started opening up posteriorly and with the continuous border jump flights from persons coming in from Central America and Mexico into Belize and repatriation and the opening of tourism, all these contributed to the second and third wave as we see currently. Next. Currently, we've done almost 300,012 tests, out of which 300,000 persons have tested positive. We've had up to date, up to the 2nd of November, 499 deaths within the country with a fatality rate of 1.83. A total number of 27,305 active confirmed cases, of which 24,000 have recovered, with a percentage of 89.5% recovered, who have recovered within the country. Next slide. COVID, the COVID deaths, as we see, we've particularly had within the last September to now, with the introduction of Delta, we've had at least 1,000, a cumulative number of 1,132 deaths within the last 6 weeks, within the last 8 weeks, if I could say. So the impact of COVID within the last month has been futile for us. It has been devastating, and many of those persons who have been passing away are those from and above. Mostly of those persons who are not vaccinated, representing more than 70% of.
Dr. Mori, we're not hearing you. Check that you're not muted, please.
Next slide, please. In regards to COVID hospitalizations, next slide. Yeah, in regards to COVID hospitalization, there has not been much difference in regards to the sexes, but yes, in regards to the persons who have been passing away. And this is where we're seeing is that male and female who are suffering from diabetes, high blood pressure, and chronic kidney disease, which are those of concern, are those who are have been hospitalized and presenting these comorbidities coming together, not so much those with cancer and obesity or HIV. But you have a person who has diabetes, you have a person who has high blood pressure, and a person who has kidney failures, all of which is the classical and deadly trio that is producing the high fatality, the high death numbers that we're seeing in the country. Next slide. In regards to those persons who have been hospitalized, we're seeing and passing away are those persons within the age of 40 to 69, which are the highest numbers of persons who have been hospitalized. We've had at least over 1,200 cases within the last, as of March 2020 to our present, the 2nd of November. This, as you see, it's a brief snapshot that was captured in late October of this year. Next slide. Hospitalization by age group, we continue to, and by comorbidity, we're talking about that particular group of persons who have high blood pressure, diabetes, and chronic kidney failure. This is a normal trend. It continues to repeat on and off countrywide, as these are the 3 diseases of concern, knowing that the health of our country is very poor, in particular due to poverty and high unemployment rate that we're currently seeing. Next slide. The hospitalization, we're seeing there has not been a particular facility in our country that has not been seen cases. We went on to create various surge plans. All our facilities were prepared with COVID units for testing. We've gone through various modalities of testing. We've gone into the COVID units within the facilities. We went into community testing. We have now opened drive-thrus where we are getting a high number of cases within the southern part of the country where there is the shift of the pandemic. I mean, it started north and it's now making its way through the farther districts of the south. What you see here, which is PGCH, which is the Punta Gorda Community Hospital, and this is where the pandemic is now reaching. Some of the villages in that area were affected in August, so in July to August, which we had to shut down various communities. They were placed in lockdown. We had to provide food incentives for the population. With this by itself, we had to change the various legislations and policies with SIs in regards to control just particular villages in the southern part of the country. Next slide. COVID-related deaths, we've seen, as we mentioned before, the pandemic started within the north part of the country, Orange Walk and Corozal, and within this is particularly the second and third wave, which has we've seen the highest number of deaths within Belize. In particular, in regards to Belize, which is the light green there, the Delta, the discovery of the Delta variant and other variants that we have in country, because we have the Alpha, the Gamma, the Delta, all these have been identified due to gene sequencing supported by the Baylor College of Medicine and CDC as of June this year. And so the particular district of Belize by itself is where there's still the highest number of cases being seen and hospitalization occurring in our only referral hospital, our only ICU unit, which is at times has become overwhelmed with more than 33 cases per day. Next slide. In regards to the COVID deaths among those partially vaccinated, we are seeing that the main cause of disease associated with deaths in the partially vaccinated continues to be the same three that I've mentioned continuously, and with the onset of obesity coming into the scenario. So we have chronic renal failure, diabetes, high blood pressure, obesity. Next slide. In regards to those fully vaccinated, diabetes is the first one, renal failure, hypertension, obesity. Next slide. In regards to COVID deaths by age, we're talking about the 60 plus, 79 plus. And so we start seeing a shift in regards to the early onset of deaths occurring in those from 40 to 49 and above, way up to the ages of 80 to 90. So there has been a trend in regards to all these persons. The elderly have been affected, but the tendency is that for the young persons to go that work, that are partying and have living their life at this point in time because they're tired of lockdowns, they're tired of curfews, they have house parties and they go to work. So they travel from the northern part of the country to Belize City, where they commute by buses. The implementation of public health measures has been quite not been that effective for us to be able to control the movement of population. So these are various scenarios in regards to public health that we've not been able to tie down and to secure that all of these are effective in controlling the pandemic. We've gone into the introduction of having the justices of the peace be identified at the stores. We've created surveillance groups to go out and see how they can police these stores as best as possible. But all these have been quite implemented to the fullest and have not been effective measures in controlling the community spread within the villages or towns. Next slide. In regards to, as we said before, these are all the facilities we've seen cases in Belize, and the highest number of deaths being in the Constitution Hospital, which is the only referral hospital. Next slide. In regards to the deaths, we are seeing that, for example, due to the third wave and in the second wave, which is the one in blue, we are seeing that the highest number of deaths began to be seen within the months of July, August, and September, which we've had within the last 4 or 5 months. We've had at least approximately less than 200 cases, 200 Belizeans passing away. Next slide. The effect of Delta. This is where we saw Delta being introduced into the country within the months of June to the July, and it was officially found in the month of August, and therefore it's associated with the high number of deaths being seen and the outbreaks that cannot be controlled in the poverty-stricken areas of Belize City. Next slide. This is basically a comparison. If you note by numbers, we're seeing that compared to 2020, the number of deaths seen in August to December were not were far more lower compared to those seen in 2021. So the third wave and the Delta and the introduction of variants have been the main cause of us seeing the larger number of deaths being seen countrywide. Next slide. And this is the final gaps, and we're talking about restructuring and task shifting of essential staff according to the national scenario. We've had all regions have surge plans. We've had officers resigning. We've had officers not willing to work. We've had budget cuts. We've had a high infection rates within healthcare workers. We also have some level of resistance with vaccination with healthcare workers. In one hospital in the western part of the country, we had almost 45% of healthcare workers being out due to COVID and outbreaks within our facilities. So that has been something that has been affecting us consistently. The increase of prices of essential medicines and reagents. We know that, for example, just to procure medicines, there was almost a 300% freight charge and insurance for these to come in country. The U.S. confiscated a lot of our medicines and equipment. The cutback on essential services within our facilities has not allowed those persons with NCDs to access services, for example, routine checkup, creatinine, urinalysis, fasting cholesterol, triglycerides, HbA1c. The fear and stigma that is associated with our COVID units has been out there. The fear of vaccination has also been another concern. We tried to hand out multi-month prescription and stocks, but if you the stocks are not coming in from your procurement officers and the persons who you buy from, which are in most cases are a tertiary person or a middle person, the stocks don't come in time. We still have issues with medications for ICU units, sedations, and other scenarios. We have had issues with the medications for mental health, which we have an increased number of persons who are not controlled, who are out there, and they need to be visited, they need the medications. We had a severe shortness of human resource and prolonged leave due to COVID. If you recall, in the first months of the pandemic, we were giving more than 14 days of sick leave. Persons still testing positive with a PCR upon 90-day period, and they would be out for extensive long hours or days. Budget allocation as per national epidemics of NCD is not there, so we have to somehow see how there's a reviewed national budget and plan and strategies for the control of NCDs in Belize. That's a brief snapshot of what we are suffering here in Belize within the last 19 months. Thank you. I apologize for going a bit fast, but I know I was against time.
You did a fantastic job, Dr. Murray, of presenting Belize's state of health in terms of NCD and COVID. We just turn to the discussion section at the present time. And let me introduce Dr. Joy St. John, who will give some remarks before we have a few questions. Dr. St. John is the Executive Director of the Caribbean Health Agency, CARPHA, and has led the response to COVID-19 pandemic. Her leadership has seen her having over 200 speaking engagements on COVID-19 over the last period. Dr. St. John, please go ahead, you have the floor.
Thank you so much, Simon, and thank you to the organizers for the opportunity to conclude the discussion on this critical topic for this panel, NCDs and Sustainable Development, the COVID-19 factor. This timely collaboration between CARPHA and ECLAC on this seminar is not just relevant. It is essential for the forecasting of some of the preparations that regional and international health and development agencies must take to help ministries of health cope with the Caribbean health sector challenges post-COVID-19. I fear that the Caribbean is ill-prepared for what will become the bread and butter recovery and rehabilitation work to get the survivors of COVID-19 to not only be functional, but to enjoy the quality of life that the Caribbean has to offer. All of this hinges on the undeniable fact that the Caribbean had an unacceptably high prevalence and incidence, especially among young people, of the NCDs and their risk factors. So now there exists a syndemic of the pandemics of the NCDs and COVID-19 that has exposed the gaps in program, the inequities in national resources, and the inherent vulnerabilities of those among us with NCDs in the Caribbean. We knew that pre-COVID-19 pandemic, Caribbean countries were off track for attaining the globally agreed commitments for NCDs and the Sustainable Development Goals. Now at the height of the COVID-19 pandemic, the COVID-19 variants are mercilessly highlighting this, the most vulnerable population, through giving them severe COVID illness and killing them even when they are fully vaccinated, and setting up rehabilitation nightmares for governments through the range of strange manifestations due to long COVID. It pains me that the Caribbean is in this state at this time, not just because I hate to see avoidable illness and death, but more so because our political leaders had the foresight in 2007 to design the blueprint for improved NCD prevention and management and to mandate a roadmap for action. CARICOM heads of government committed to the first of its kind regional commitment, the Port of Spain Declaration. And they started a cascade of political interventions which made the world stop and pay attention. This culminated in 2011 at the UN, with only the second time in the UN history that a health problem was elevated to this level. The UN Political Declaration on NCDs 2011 was followed by the 2014 and 2018 reviews and declarations. And of course, in 2015, for the first time, NCDs was included in the Sustainable Development Goals. The challenges posed by NCDs to sustainable development are many. The failure of countries to prevent and reverse the rise in NCDs through policy interventions has made their populations more vulnerable in ways that transcend simple illness on a personal level and raise the sequelae to economic burdens and crises which reverse development gains. Just ponder on how the COVID-19 pandemic has rocked the tourism sector and almost bankrupted the economies of the CARICOM countries. The COVID-19 pandemic has further retarded progress to reduce premature mortality and incidence due to NCDs by increased death of persons with NCDs and their risk factors due to COVID-19 infection. The NCD burden is also increasing as a result of complications due to COVID-19 infection, such as cardiovascular disease, diabetes, let us not forget mental illness. As the health services are consumed by managing the COVID response, the resources to manage the everyday issues of NCDs and plan for expansion of the NCD programs have been less than optimal, and the absence of health sector-driven compliance and management is creating its own challenges. And of course, COVID-19 has also exacerbated food and nutrition insecurity. Women, children, the elderly are particularly vulnerable to hunger and food insecurity indicators, especially given the reduction in household income from COVID-19. Please recall that the major drivers of the response to NCDs lie largely outside of the health sector, and a multi-sectoral approach, including the necessity for policy change and ring-fenced budgeting to address sectoral action, Are the paradigm shifts required, not just for health, but also for finance, industry, education, agriculture, trade, and transport sectors? There needs to be much more done at the intersections of health and these different sectors, and even more economic analysis of the interventions so that the maximum impact sectoral actions are financed from national budgets. We must look to address inequities as a priority and move towards a holistic, whole of society approach towards addressing public health matters, including NCDs and the health response. We can utilize lessons from the COVID-19 pandemic response to advance the NCD response, as many of the tools required to fight the pandemic are similar. For example, national multi-sectoral action plans, coordination of response across sectors, and quick changes in legislation development to protect the public's health. Due to COVID-19 public health measures, there have been some innovations implemented by Caribbean countries like telemedicine care and home delivery of medications, which need to be re-evaluated. We also need to assess if the pre-pandemic burden of NCDs, if the pre-pandemic burden of NCDs has changed and the effects of COVID-19 on the NCD response. All of this is in order to identify COVID-19 best practices that can be translated to the upscaling of the pre-existing NCD response. As a result, the COVID-19 pandemic presents an opportunity to refocus on NCDs and health and rethink the response, recommit to a multi-sectoral way of fighting the epidemic, and quadruple the measures if we are to achieve the SDGs. This discourse on NCDs and SDGs is healthy, pun intended. And this collaboration with ECLAC should continue as we collectively clamor for whole of society efforts at achieving the SDGs and for the Caribbean way of fighting NCDs simultaneously with COVID-19 to be recognized. I thank you.
Thank you, Dr. St. John. And I just wanted to thank all the speakers, Dr. Kavita Singh, Dr. Kenneth George, Dr. Francis Maury, and Professor Fitzroy Henry for leading us through a very fruitful discourse in relation to these problems. As we know, the pandemic has halted or reversed progress in health and has shortened life expectancy, not just in the Caribbean, but globally. And as such, a decade of progress is being lost. Part of the problem is the lack of infrastructure and the lack of data, because we need to be able to have this data to understand what COVID is doing. We will try to get a couple of questions. I did not see any comments or questions in the chat. I have a couple of questions which I'll just ask to the team, and then we'll hand over to my colleague, Professor Abdul Kari. Chair, if you may allow me to ask one question of the floor, and we probably just get colleagues to answer. How can we implement the adoption or the scale up and the scale out of the factors, the tools, the tasks that we have to do in the region, Latin America and the Caribbean, so that we can effectively reach our goals or to catch up, to remove the gap. Are there any comments or questions in relation to that question? Dr. St. John, you look like you want to answer that one.
So I can try.
Oh, thank you, Dr.
Yes,
George.
I prefer Dr. George to start, and then I can add in a little bit.
No, so Dr. St. John was very right. I think the focus needs to be a whole of society approach. Every single agency needs to be functioning. It can't be a government response only. I think for Barbados, we have tried to use that in our approach to COVID. It cannot be solved with a medical approach. And therefore, we have used the intersectoral approach to address these issues. This needs to continue with the NCDs. I'm in agreement that there needs to be a continued push for more data with respect to understanding COVID, not only COVID, but the NCD pandemic, because I personally believe the pandemic will be here for a period of time, but the NCD issues will remain in the region for an extremely long time and will outlive the whole issues of a pandemic. So I'm in agreement with Dr. St. John. We need to learn from the issues that came out of COVID, return to a primary health care approach, and use all sectors within society to move forward on this issue. Thank you.
See.
Thank you, Dr. George. Dr. St. John, a response?
So I think I'm going to speak from the regional level now, because I wanted to hear the national perspective. But I think we need to engage the sectors that hold the purse strings. And CARF is actually working with several entities right now on designing such an encounter. Let me call it an encounter. I don't want to call it a meeting. Such an encounter where we will present the evidence, because where's Ms. Corliss? One of the first things that I remember since I became executive director is Diane Corliss saying that the Caribbean shoots itself in the foot. Well, she didn't say it, but this is my paraphrase. Caribbean shoots itself in the foot by not giving the evidence and not reporting it in a manner that international agencies will take notice, because we small dot in the geographical context of things, and an even smaller dot when it comes to numbers of people. We're going to present the evidence we have in such a way to the sectors that they realize the cost of doing nothing, which is what we're very good at doing in the Caribbean. So that there can be no question that there needs to be more resourcing of NCD programs. We always get caught in this trap of financing what is sexy and obvious for our ministers, and NCDs are a slow burn. But COVID-19, I think, woke up several of the non-health sectors as to the importance of not paying due attention financially to the resourcing of your programs. So we're going to bring the sectors together, give them the information, get them to talk to us about how they do their own processes and how it is easy to roll into their own processes and planning what is needed for upscaling and resourcing. Nothing like evidence, and nothing like getting people to say, oh, this is simple. I do this every day. I can add this on. Over.
Thank you, Dr. St. John. You've packaged everything very nicely for us. I will just give the other speakers, Dr. Henry, Dr. Singh, and Dr. Morley, if you're still here, just an opportunity to make one last comment before we hand over to Professor Abdulkari for his segment.
Yeah, thank you, Simon. Just to say that this pandemic and other pandemics will come and they will go. Some will take longer than others. We do have other short-term crises such as floods and hurricanes in the Caribbean. And I put those in one bracket and making the point that our underlying systems need to be robust to really cushion the effects of these pandemics and the shocks that will come from time to time. So as far as nutrition is concerned, we really need to look at two things. One, the short-term response and the medium to long-term response. The short-term, based on evidence, as Joy said, we have to look at the allocation, we have to do risk mapping. We know the areas that are prone to these challenges, and the same areas that affect us with COVID are the ones that the disadvantaged communities that affect us when we have floods and hurricanes. So we need to look at that, make sure that the responses are nutrition sensitive. Don't just give food for the sake of food for relief, but we have to look at NCDs and the consequences of how we respond. And in terms of the medium term, we really have to look at sustainable, available, nutritious foods, whether it is local, and make sure, again, those are nutrition sensitive in producing it, which means the agriculture sector needs to get involved. And even with the imports, because, you know, we have to import to support the supply and needs of our population. We have to be aware of these ultra-processed foods that we're importing. So these are the things that will solve our underlying problems to make our nutrition systems robust, so that when these pandemics come, and you bet they will come, and when the shocks come, they will come, we have a robust system to respond to them. So that's my take on this. I hope that Minister Gonzalez would be happy to hear some of these responses as he called for. I hope he can take the lead at that level so that we can move on the Port of Spain Declaration where all of these things have been laid down. Thank you.
Thank you, Prof. Thank you, Prof. Dr. Singh, any last words, and then I'll hand over to the chair, Honorable Gonzalez.
Thank you, Dr. Ederson. Nothing more to add to what the other experts have already mentioned. Just to bring up one point, that we do have evidence on a number of interventions that works in terms of reducing the disparities or to bridge the gaps and no-do gaps. So I think what's needed here and going forward is more of implementation science to, you know, implement what we already know and involve multiple stakeholders to make the interventions more sustainable. And I do see digital health interventions do offer a promise going forward to bridge the care gaps that the pandemic has brought in. Thank you very much.
Thank you very much, Dr. Singh, and thank you very much for this session. Over to you, Honorable Gonzalez.
Thank you very much, Dr. Anderson, for excellent job moderating that panel. I thank, of course, the very distinguished panel that we had with our institutional advice from the University of the West Indies and UTEC and CARFA, and country perspectives, Belize, Barbados, and even India. Dr. Singh, thank you. Very important, and I think that the final comments by Dr. St. John were a very effective segue to the next panel that we want to conduct, because Dr. St. John was talking about presentation of information. She was talking about engaging those who hold the purse strings, and she was therefore talking very directly to the issue of statistics, of data, and of course of applying the economic policies and theories that have been brought to bear in fighting the COVID pandemic most directly, into also using them more aggressively against the NCDs. So I would now invite you to consider the second panel that we have, and to thank Dr. St. John for her segue. And the second panel is called Economics of NCD Prevention and Control. which would speak to the NCD problem as a development issue requiring economic analysis and highlighting the economic burden of NCDs and also identifying the economic policy options that we might wish to consider in our national strategies to manage both NCDs and COVID-19. Of course, some of the things brought to bear against COVID in this emergency period were brought to bear specifically because we were in a public health emergency or a state of emergency, and some adjustments were obviously more easy to do in that context. But I think there are a lot of lessons to be learned. I think some of the other panelists have pointed that out. And just as Dr. Singh said, and just as Dr. Henry indicated, there are things that work. And there is data that supports some of these things that work. And we have to see what we can do to either incentivize those good responses or to further penalize the bad ones. And that's usually where the economists come in dealing with us supposedly rational individuals that can be incentivized to do good and bad things. So we have yet another group of experts in the field who will lead our reflections on this issue. We have Mr. Abdullahi Abdul Kadi, the coordinator of the Statistics and Social Development Unit at ECLAC Subregional Headquarters in the Caribbean, who will moderate this session. Mr. Abdul Kari leads the team in Port of Spain that provides technical assistance to our member states, countries on statistical capacity building, including the establishment of national statistical systems. His team also supports the implementation, follow-up, and review of the 2030 Agenda for Sustainable Development and the Sustainable Development Goals, which of course are under real threat given the results of the last 2 years of our pandemic. Before joining ECLAC, Mr. Abdul Kari was a professor of applied economics at the University of West Indies Mona campus, where he served as the Associate Dean for Research and Innovation in the Faculty of Social Sciences. And it's my great pleasure to now give the floor to Mr. Abdul Kari to introduce his panel. Mr. Abdul Kadri, you have the floor, sir.
Thank you very much, Honorable Minister Gonsalves. Good morning, Ms. Bastana. Good morning, Ms. Collins, the distinguished panelists of the panel one, and of course, my very good friend, Professor Anderson. That was a very interesting panel that we just had. And I'm hoping that we will have panel two to be as interesting as panel one was. But because we are really running out of time, I would like us to get straight to the matter, where for panel two, we will be looking at economics of NCD prevention and control. This is an important topic, and you could tell that from the remarks that Ms. Bastana gave, and of course the remarks from the Honorable Minister as well. So we have an eminent panel of distinguished scholars to also lead us in this discussion. The challenge that I have now is to manage time. So I have to plead for your indulgence earlier on that we have 15 minutes for each presenter, and at about 12 minutes, I will interrupt you to let you know that you have about 3 minutes to conclude your presentation so that we will have time for discussion at the end. That being said, I will introduce the first panelist in person of Dr. Anselm Hennis, who will give a presentation on the economic dimensions of NCDs in Latin America and the Caribbean. Dr. Hennis is director of the Department of Non-Communicable Diseases and Mental Health at the Pan-American Health Organization, the WHO of the Americas. His department coordinates activities on non-communicable diseases and related risk factors, nutrition, violence, injuries, road safety, disabilities, and mental health, as well as illicit substance use throughout the Americas. He graduated in medicine from the University of the West Indies and qualified in internal medicine in the United Kingdom. Dr. A. Hennis was Wellcome Trust Clinical Epidemiology Fellow and obtained MSc and PhD degrees in epidemiology at the London School of Hygiene and Tropical Medicine of the University of London. He has been Professor of Medicine and Epidemiology at the University of West Indies and Research Associate Professor in Preventive Medicine at Stony Brook University in New York. Dr. Haynes has worked to tackle NCDs through clinical practice, teaching, research, and publication, working with civil society and throughout public health practice. Professor Haynes, the floor is yours. You have 15 minutes.
Why, Dr. Abdullah, I'm going to share the screen now, if I can. Sorry, share. Good, and can you see me? Good. Can you see the screen?
Yes.
Wonderful. Okay,
Yes.
good. So my brief this morning is to speak about economic dimensions of non-communicable disease in Latin America and the Caribbean, and all precedents have been established. I'm going to go straight ahead, particularly given the time. And the outline of this presentation is about the health burden of NCDs and mental health, the economic burden of these conditions, cost-effective interventions, NCDs and mental health investment cases, and other lines of action. Now, of course, I'll touch on the COVID pandemic. Now, as you know, there are 4 principal NCDs: cardiovascular diseases, chronic respiratory diseases, cancers, and diabetes, in addition to mental health disorders, which come under the 5x5 mandate that WHO leads in the Global Action Plan. The risk factors are unhealthy diets, consumption of tobacco, air pollution, harmful use of alcohol, and physical inactivity. And these are the things that we have to tackle to reduce the burden of NCDs. Now, of the 7 million or so deaths in the region of the Americas annually, 80% or 5.8 million are due to NCDs. And a third of NCDs occur prematurely in persons aged 30 to 70 years. Now, there's a significant economic burden of NCDs. And this is a theoretical framework for the burden of NCDs. And there's been a lot said about it this morning, including by Minister Gonzalez, by all the other panelists. So I won't dwell too much on it, but to really point out that the impact is at every level of our functioning. At the individual level, at the household level, it affects incomes of those who are ill. It may cause impoverishment. It may cause increased health expenditures. It affects human capital. It affects health systems, increases costs of treatment, demands for services. It affects government and public expenditure. It reduces tax revenue, etc. And it also affects capital investments, decreases labor supplies, and increases poverty and inequality. So it ends up creating a vicious circle. Now, David Blue and company and collaborators at Harvard University, with whom we have collaborated extensively as well, they actually conducted a study in 2011 in which they estimated that the global losses in output due to NCDs and mental health in the period between 2011 and 2030 would be $47 trillion, accounting for 75% of the global gross domestic product. It would also particularly affect lower middle income countries, which will contribute about 40% of that overall loss. So a significant loss due to NCDs. Now, some of the methodology was used to estimate the actual impact of NCDs and losses in the region. And they used the same EPIC model. And this study was conducted in Costa Rica, Jamaica, and Peru. And it showed that if there was no action, the cost of inaction related to NCDs would result in about $82 billion in losses between 2015 and 2030 in Costa Rica, $18.5 billion in Jamaica, and $477 billion would be lost in Peru due to non-communicable diseases. So tremendous impact. Now, this slide shows here development assistance for health. And this really measures the both the real investments as well as in-kind contributions to low and middle income countries. And what it shows is that although NCDs account for 50% of the global burden of disease, there's only a 2% investment from development assistance for health. And in contrast, while HIV/AIDS accounts for about 4% of the overall disease burden, it attracts more than 30% of the development assistance for health. But there is good news, of course. And the news is that there are cost-effective interventions for NCDs, the so-called best buys. Now, what are the best buys? The best buys basically are those very cost-effective interventions at a cost for $100 international can avert one disability-adjusted life year in low and middle-income countries. So it's regarded as being highly effective. There are a total of 88 good buys, but of those, 16 are the best buys. I'm going to take you through a little bit to show you what they look like. And basically, they tackle tobacco, they tackle alcoholic beverages, and these are usually tackled through regulation, taxes, banning advertising, promotion, and sponsorship, and the like, as well as in terms of nutrition, reducing salt intake. And it includes front of package labeling, which I think was mentioned this morning, which the Caribbean has been evaluating. It also looks at the whole issue of being more physically active. It looks at provision of drug therapies to improve diabetes and hypertension and to reduce cardiovascular adverse events. And it also looks at preventing and treating cervical cancer by vaccination against human papillomavirus or early screening, detection, and management. So these are highly cost-effective approaches. Now, what this slide here shows is that it's based on an ambitious scale-up where all policy interventions are immediately implemented and pharmaceutical interventions reach 50% coverage in 2030. And many of these investments are in prevention activities. As such, although investments are required immediately, benefits will only begin to be seen in subsequent years. So this looks at what would happen if one were to invest in terms of the best buys to save lives, spend less. There will be tremendous return on investments by 2030. So one would get a tremendous return on this investment if you were to invest in the best buys. This slide here makes the case that for every $1 in WHO best buys, which we have done a quick look through, and the best buys to tackle non-communicable diseases, it will lead to a return on investment of at least $7 by 2030. So $1 investment leads to a $7 return. And this is largely by policies and investing in health systems and services. So if one looks at the model and takes it forward to its national conclusion, looking at investments in low and middle income countries, implementing the best buys from the NCDs will generate $350 billion in economic worth between now and 2030. Now, so basically, while they're cost beneficial, it doesn't mean that they're necessarily taken up by the countries. This slide here shows the aggregate policy implementation score, which is a measure in terms of the implementation of the best buys against the Human Capital Index. Now, the Human Capital Index is a summary measure of the amount of human capital that a child born today can expect to acquire by age 18, given the risk of poor health and poor education. So in other words, it's a reflection of national investment in the citizenship of a country. So if one invests so that the child has education, the child has good health, in return, the child can contribute to economic development. And so what this says is that countries that invest heavily in the Human Capital Index are those most likely to benefit by implementing the NCD best buys. And the lower and middle income countries, which have lower levels of investment, actually have lower levels of investment as well in terms of the NCD best buys. So it really is a bit of a catch-22. Countries need to recognize that investment will make the difference that is needed to improve productivity and outcomes. And this is far more important in this day and age now in the year of the COVID pandemic. So what is an NCD and mental health investment case? The economic analysis produces the return on investment. The institutional context analysis now produces an understanding of the political and institutional context within which the model interventions will be introduced. And together, these form the investment case. So it's not just merely the return on investment analysis, but we have to have an enabling environment, which is the institutional context, which is driven by the political and the institutional context. So investment cases serve to facilitate intersectoral dialogue to improve understanding of the economics of NCDs and mental health, including the scope of the problem and the feasibility of the interventions. It provides ministries of health with tools to advocate effectively with other ministries for greater investment in NCD prevention and control measures and the treatment of mental disorders. Thirdly, it promotes policy coherence related to NCDs and their risk factors, as well as mental health, through the use of economic and health evidence among decision makers across all sectors. And fourthly, it strengthens the national capacity to conduct economic analysis of NCDs and mental health. Since 2015, 54 countries have requested tailor-made investment cases to develop more effective NCD responses globally. In spite of 54 countries requesting to date, 19 have been done in NCDs, 9 are in progress, some have not been done at all. There's been 1 done in mental health and 7 in progress. So in the region of the Americas, Barbados, Jamaica, and Peru have completed investment cases. Suriname is about to start, and Suriname is close to completing their investment case, and Guyana has just started. So what can we learn from these investment cases? Now, this slide speaks to the whole issue of an investment case for NCDs and mental health conducted in Jamaica. And what it shows is that the overall return on investment calculated for the prevention and control of NCDs in 15 years in Jamaica is actually $2.1 US for every $1 invested. So here it is. So for every $1 US invested for NCDs, you're going to get a $2.1 Jamaica return on that investment. And then in terms of mental health, it's even bigger. So down here, for every one Jamaican dollar invested, there's a 4.2 return on investment. So there's an overall return on investment in Jamaica of $2.8 for every $1 invested. This speaks to the situation in Peru. It's in Spanish, but never mind. I think the key things that we're going to show you, I'm not going to go through all the background of all the different risk factors and NCDs considered, but the principle is what I'm trying to highlight to you. What it says in terms of the return on investment for NCDs, for every 1 SOLE investment in Peru, the return on investment is 2.5. For mental health, for every 1 SOLE, it's 1.6 return. Overall, for NCDs and mental health, for every 1 SOLE that's invested, there's a doubling of the return on that investment. So as I said before, that the investment case for the prevention and control of NCDs and mental health in Suriname is expected to be completed in early 2022, and it's about to start in Guyana. Now, I'm going to focus a little bit on this slide for the whole issue of COVID. So NCDs, as you have heard from many of the presenters this morning, they have increased adverse COVID outcomes. People who have NCDs, for example, of diabetes, is a doubling the risk of death, etc. In some studies in the US, there's a higher risk of hospitalization. There's also the whole issue of delayed screening, which Professor Henry spoke about in detail, and delayed treatments due to service disruptions. There are also longer-term implications of service disruptions. So we expect to see a higher burden, for example, of complications of cancers and maybe cardiovascular disease and diabetes complications. And secondly, to the whole issue of long COVID, which Dr. St. John spoke about. So we don't quite yet know what to expect of long COVID, but we recognize it's a multi-system disorder, which is extremely disabling, which is one of the developments with COVID that we're now learning a lot more about. And we expect it to create a tremendous negative impact on the health systems and services in this region. Another big issue is the issue of mental health. This has created a silent pandemic with current and future impacts, which are well beyond the capacity of most countries in the region to manage. This is a silent pandemic which affects your young people who have not been able to form social networks and socialization, who've been out of school, and there's a concept of the lost generation. So we have to think about the greater burden of mental health as well. Additionally, there's been reversal of gains in NCD risk factors, nutrition. Dr. Henry spoke about that, but there are also issues in terms of greater uptake of tobacco use, alcohol use, which are also mentioned by some of the presenters, which is also going to burden our health systems and cause greater burdens of ill health. So in other words, we can see the immediate impact of COVID as a pandemic, but NCDs, as Dr. St. John said, is a slow burn. It's also a pandemic in its own right, but we just don't see it for what it is. We also know that those living in low and middle income countries and in conditions of vulnerability are most affected. So strengthening regulation of risk factors, investments in NCDs and mental health services will lead to returns on investments. And I think that's the key message here. Invest and you get a return on investment. This must be the way forward in terms of how we think about strengthening policies and why we need to invest as we transform our health systems and services to strengthen the approach to NCDs and primary health care towards universal health coverage as we build back better and fairer coming out of the pandemic. So other lines of action that PAHO is using in terms of this economic space is building an economic case for action in NCDs within and beyond the health sector, the impact of NCDs on economic growth, economic cases of NCDs, the Framework Convention Tobacco Control Investment Case, among others. Also, evidence and tools for designing, monitoring, and evaluating tax policies for health. And this includes issues like, in addition to tobacco, sugar sweetened beverage demand analysis, simulation tools for tax policy design, as well as promoting intersectoral dialogue on health and fiscal policy coherence. So really a lot of work that needs to be done to be able to regain health in the context of the pandemic. Thank you for your attention.
Thank you so much, Dr. Hennis, for that very informative presentation and for keeping within time limits. So I think we're doing very well. I'm not going to make any attempt to summarize your presentation, but for the benefit of our participants, we will be taking questions and your comments after all the panelists are presented. So I'm going to thank you, Dr. Hennis. Thank you again. Now I'm going to move on to the next presenter in the person of Dr. Richard Nugent, who will be presenting on investing in NCD prevention and control. So we will hear more about the case for investing in NCD prevention and control that Dr. Hennis touched on in his presentation. Dr. Nugent is an affiliate associate professor with the Department of Global Health at the University of Washington. She has more than 30 years of experience in global development as a researcher, practitioner, and policy advisor to governments. She is the Vice President and Director of the Center for Global NCDs at the RTI International, where she leads a team charged with providing policy analysis, implementation, and evaluation of cost-effective strategies to prevent and control global non-communicable diseases. RTI's global NCD expert generate and translate new evidence to help guide global and national decision-making aimed at non-communicable disease detection, prevention, and control. Dr. Nugent manages the center's capabilities, including health economics and evaluation, communication and behavior change, epidemiology and survey research, establishment of disease and risk factor registries, and development of guidelines, care pathways, and medical technology application for global NCD. With that kind of resume, we will be glued to our screen to hear what Dr. Nugent has to tell us about investing in NCD prevention and control. The floor is yours, Dr. Nugent. You have 15 minutes.
Thank you so much. And thank you to the sponsors at ECLAC and my colleagues at PAHO for including me in this. I'm going to screen share as well. And I'm going to thank, see if I can, okay. This always takes a moment. Especially with different platforms that we use, we have to look for the right buttons. Okay, are you seeing a slide show?
Yes, we're seeing it. You just need to put it in presentation mode.
Yes, that's
Yep.
working on that here. Okay, how's that look?
Yes, perfect.
Okay, great, thank you. I'm going to thank Dr. Hennis for covering a lot of the reasons and some of the details behind the investment case approach for addressing non-communicable diseases. What we found over the years is that these economic analyses have resonance with important decision makers, and they have resonance with the population and with the media as well. So I'm going to cover a few more highlights just to complement what Dr. Hennis has said, and try not to cover the same ground, but just to sort of give you a somewhat more elaborated and richer view of these investment cases where we use economic analysis. So very briefly, the objectives, of course, are to demonstrate the benefits of investing in a set of prioritized NCD interventions, and to quantify. Usually we start with quantifying the economic burden. So what are the economic costs? We look at the health costs. We talk about the health costs a lot as public health people, but we don't always talk about the economic aspects. And that's what the purpose of these is to sort of bring in that other dimension, to speak in a different language, sometimes to different audiences about the same thing, because the goals are the same. These investment cases and the whole connection between NCDs and economic development, and our session is about NCDs and sustainable development. These have been represented well in global publications such as this Lancet series that was published about 3 years ago. We talked about the connection between NCDs and SDGs here, and we had a global investment case analysis in this series, along with several other papers, to make this connection. And I think that was probably a very seminal moment for NCDs to really highlight this really is a sustainable development issue. And even though the Caribbean region, the CARICOM countries had put NCDs on the map years before with the Port of Spain Declaration and bringing these issues to the UN General Assembly. So they were very much part of the discussion. The economic aspects of it had not been as prominent, and in particular, as Dr. Hennis showed a little bit ago, there was really no energy, no interest among donors to be addressing NCDs. There were a lot of kind of strange ideas about, well, you know, those don't happen in lower resource settings, or those aren't the priority because we are still dealing with infectious diseases, or, you know, the solutions are already there. You just have to do what richer countries are doing. I mean, these are the kinds of things that I think people had in mind, and then we were able to address those very wrong views, you know, very misguided views, by putting forth this evidence and building this evidence, which is what's continuing to happen with the participation of PAHO, of course, and UNDP. So what we're talking about here, though, I think today is more at the national level. What are countries doing? What else can they be doing? There was talk earlier in the seminar about feeling that things had stalled somewhat, that maybe we know what to do, but we don't know enough about how to do it. And again, here, the investment cases can be helpful. Yes, very often they're used for advocacy to motivate and mobilize action and funds. And that's an absolutely essential first step. They can quantify the economic burden, and that's a lot of what Dr. Hennis showed you earlier, and I'll come back to briefly. They provide country-specific evidence for policymakers. So when we have these global measures, like David Bloom's $47 trillion, that is an eye-opener, but it's not clear how much that motivates decision makers within a country, because that seems very, very big and far away. So country-specific evidence is critical, as we know. And therefore, it can inform decisions and help shape priority setting, because at the end of the day, decision makers have to set priorities. They have to make those tough decisions. And so providing some evidence to help them do that. It's not the only evidence that comes into play. There are other factors, but the economic evidence can be a very useful factor for them to point to support decisions that they want to make to buy the most health for the money available. And then finally, the institutional context analysis, which was mentioned earlier, is so critical for understanding the political environment, the stakeholders, and so on. So I'll talk a little bit more about that in a moment, but just, you know, how does one do an investment case? You know, what do these things actually entail? We've shown you, or Dr. Hennis showed you some results, but here's the steps. It's, you know, really economists are fairly simple people. We like to sort of take out our tools and use those tools to analyze different kinds of problems. So we look at the mortality and morbidity. So what is the burden of NCDs and where is it among the population? We estimate the costs of that burden, which is what we call direct and indirect costs, which I'll tease out in a moment here. Then the interventions, you already have heard about the Best Buys, you know them well, I think probably, and we estimate the impact as much as possible with country-specific data, country-specific research and studies where possible, or as close as we can to what we think would happen in a given country if we have evidence from elsewhere, how much of it is transferable. And we have discussions in the country about that, you know, with the people who are researchers, who are policymakers. We estimate the financial costs of implementing and scaling up those interventions, and then of course get the return on investment. That's sort of the simple cookbook steps that we take. There's a lot of details in the modeling effort and the data gathering effort behind that. But here's an example, just one quick example. Actually, this is from El Salvador, and it's from a tobacco investment case. So it's not a full NCD spectrum, but looking at tobacco, we looked at, we estimated the direct costs and the indirect costs, what I just mentioned before. The direct are those ones that are in yellow and gold, and those are healthcare expenditures, whether they might be expenditures that are paid by insurance, paid by the government often, or paid actually out of pocket by households or by private businesses where it's more difficult to get information. But businesses, of course, do bear a burden when their workers have to go to the doctor. Some of them are paying directly for that. And that is apart from the productivity impacts, which are the purple and lavender slices here in the pie chart. And here again, this is tobacco. So you see a slot that accounts for smoking breaks, that smokers take more breaks during the workday than other people do. And in some countries, in El Salvador and some other countries, it was wanted to measure that. They wanted to measure that effect along with the premature mortality and the productivity impacts, the other productivity impacts that we usually measure, presenteeism and absenteeism. That you've probably heard about before, when people don't come to work or when they're not very healthy when they come to work. So that's an example of the kind of results that we're looking for that we can offer to a country. You know the Best Buys. I'm not going to walk through them because you heard about them from Dr. Hennis, but the point that I want to make here in mentioning them, here's preventive Best Buys, and here's some of the treatment and disease management Best Buys, good evidence, but you know, it all depends on the country context, right? It may be that raising taxes on tobacco further than they are, or putting bans on junk foods in school, or other kinds of things that are on the Best Buy list are not as practical in some countries as in others, or feasible or desirable. There's a lot of reasons why countries need to bring their specific context, and that's both in terms of the political will, the feasibility of implementation, and the costs, to this list, which is a generic list, and then think about, okay, you know, which ones do we choose? If we're not doing all of these, why not? Are there others we should think about, or other things that are not on this list? Because there are other kinds of prevention and treatment approaches that are also cost effective that are not on this list. And as we build out the evidence, as more and more NCD management is happening, we learn more about what can be cost effective. I put up these quotes here just to illustrate sort of the contextual aspects, and I'm sure many of you will recognize where some of these quotes come from. these are direct quotes from people in Ministry of Health or other ministries about what might be possible in the countries that have asked for investment cases and that want this analysis. So quickly moving on here, just a mention of Jamaica. It was mentioned earlier that Barbados was the first country that did ask for and conduct an NCD investment case. Jamaica was one of the very, very early ones as well. And people from Jamaica here, I'm sure will recognize the spot. We worked with UNDP and with PAHO. Whoops, I'm not going to talk about the results especially, except to say this is what it can look like when we have analyzed a set of interventions here, just 4 in this case, for tobacco, diabetes, CBD, and alcohol, packages for each of those. And you can see the ROI part, the return on investment, is the value of what you get back, the benefits, over the costs or divided by the costs. And you can see that the ROI for NCDs generally grows higher with the passing of years because you reduce the premature mortality and the disease, the morbidity, the illnesses. The sooner you have put in place these investments, the costs sometimes come up front and the benefits come a little later. So the ROI can grow over time, which is a difficult thing for a politician to deal with sometimes. And I have to applaud the minister from Jamaica, who was at the time and is consistently a supporter of how investing in NCD prevention and control is improving the economy in Jamaica and helping to reach the development goals that have been set by the Prime Minister. Real quickly on COVID, we've talked about COVID a lot today. I just wanted to mention a study that we have done that is about to be published by World Obesity, our partner here, where we looked at the excess outcomes of people living with obesity from COVID. And we all know that obesity and some of the other NCD risk factors are major risk factors for COVID severity and mortality. And so here are some numbers that we calculated, that those living with obesity have 18% higher hospitalization, 42%, almost 43% higher ICU admission, and 13.4% higher death, excess outcomes from the norm because of the pandemic. So very, very serious, as many people today have already mentioned. So I just want to sort of summarize in the last couple of slides, what works here. And I'll show you a couple of impacts in a moment. We've been tracking impacts, and those can be legislative impacts, regulatory impacts, new ways of doing whole of government, whole of society approaches. And I think that, again, the Caribbean area region has been especially proactive, and I think well demonstrated the connections between NCDs and nutrition and food systems and other ministries as well. So it has to be demand driven. It has to be something that is going to be useful in the country. It has to involve trust, and that is difficult across ministries and especially across public and private sectors, but I've seen it work. It involves meetings with different stakeholders, the civil society stakeholders and others, to talk about what's important to them. Getting as much as possible local data. It's not always possible to have all the data in the model that we need to be coming from local sources, but as much as we can. We try to do fairly simple modeling. And at the end of the day, this is a complex topic, and the modeling can be kind of complex. And in fact, we're trying to get more sophisticated in some ways, accounting better for comorbidities, looking at other aspects of the population. For instance, we're working on child obesity and investment cases in Mexico, and another one to come in the region, in the ECLAC region that UNICEF is supporting. So those become a little more complicated because we're looking at life cycle impacts, health and economic impacts. And then finally, we try to communicate very widely during and after the investment case. And some of the ways of communicating the story, here's a few examples, primarily from El Salvador. You'll see our friend Rosa there. You'll see in a moment. I guess, again, I mentioned the ministers from Jamaica who've really highlighted and promoted the importance of this, been champions. And many, many investment cases have now been completed across the world and we learn something with each and every one. It gets a little bit more, probably a little prettier to present results, more webinars and meetings. And there, as Dr. Henna said, there are ongoing ones in your region. So just lastly, Barbados, that was an early investment case. One of the reported impacts was the workplace wellness policy that was adopted following the investment case, citing the investment case as one of the rationales. Similarly, in Jamaica, there was a much more rapid scale up of Jamaica Moves, the healthy lifestyle physical activity program. And I know there have been subsequent actions in Jamaica as well. So we try to, UNDP as our partner tries to track a lot of these, and we have many, many more examples that I could share with the group if you're interested. But I just right now want to close by thanking you, thanking the sponsors here, and I look forward to our discussion. Over.
Thank you so much, Dr. Nugent, for that very interesting and compelling presentation. And we will get to the discussion where I will have my own questions to ask. So right now, let's move on to the next presenter in person of Dr. Stanley Larter, who will continue the discussion. His presentation is going to be on public-private partnership to manage NCDs. So we will still be talking about investing in prevention and control. And so his topic is public-private partnership to manage NCDs, strengthening chronic disease prescription drug plans in the Caribbean. Dr. Larter is a research advisor at the Health Economics Unit, the Center for Health Economics in Trinidad and Tobago. He is a health economist with over 25 years of experience in teaching, training, consulting, and policy research in health development matters in the English as well as Dutch-speaking Caribbean. His special interests and publications are in universal health coverage, health financing, chronic diseases, and pharmacoeconomics. He was a member of the Caribbean Commission on Health and Development, which was chaired by Sir George Allen. And that commission charted a roadmap for health policy reforms and programs in the Caribbean. Dr. Larter, the floor is yours, and you have 15 minutes.
Thank you very much, Mr. Chairman, and greetings to you, to Minister Gonzalez from St. Vincent and Grenadines, to my colleagues from different organizations and countries. I'm going to share the presentation, but I'm going to turn off my video. It's better you look at the slides and look at my face. So let's get rid of my face and let's get the presentation. Be on screen, Mr. Chairman?
Yes, we are seeing your screen. You just need to put it in presentation mode. Be good to go. Excellent.
Yeah.
Yes.
This presentation seeks to build on some of the information which we've already heard from our previous presenters. It tries to take a look at a specific type of intervention in the Caribbean pertaining to the establishment of these dedicated, unique prescription drug assistance plans for chronic diseases. To an extent, Professor Hennis has already indicated that among the best buys, drug therapy for diabetes and hypertension. But then this poses another big set of questions. So what do we tell the person suffering with asthma? Or what do we tell the persons with glaucoma? What do we tell the persons who have high cholesterol, who have epilepsy and all of these other conditions, which are very crucial to them? So probably we might look to see how we can extend that. The presentation itself tries to make 3 critical points. Firstly, that Caribbean countries are faced with a major burden of chronic disease, but we have not been sitting on our hands. We have not been idle. We have not been seeing ourselves as victims only. Countries are doing things, have plans, have programs. Secondly, one of these major programs in place pertain to these unique dedicated prescription drug plans, and it is the partnership aspect, which was mentioned by the executive secretary, which was mentioned by a couple of the other presenters, where the partnership is what is going to work if we are going to deal with chronic disease, because it is not an issue or a matter which can only be solved by the public health sector. And thirdly, in these plans, what happens is that there are some efficiencies, there are some benefits, there are some gains, but we must also look at the gaps. And the third part of the presentation really look at some of these. The next slide looks at information which has already been presented by impact on economies, on health systems, and individuals. So no need to look at that in any great detail. It is the major part and at the bottom of the slide, where the total impact then has to relate to how does one look at NCDs pertaining to country productivity, competitiveness of the country, fiscal pressures on the government to keep putting more resources to make trade-offs, which sectors should we give priority to, health outcomes in the population and whether we are maximizing human capital, we don't pay emphasis on chronic diseases, and then the broader issues brought out by Professor Fitzroy Henry and others pertaining to the matter of poverty, inequity in our societies, and whether by not dealing with the problem, we are in fact entrenching poverty and inequity in the countries. Really then, what is the major rationale for the design and the development of these programs? They are looking at unique state-sponsored plans, public money, private providers of the medication, dedicated to assist patients with chronic diseases to manage their condition, improving access to quality prescription medications in participating private pharmacies without having to face financial distress. Crucial because this also links to what we want to look at pertaining to universal health coverage. As I indicated, it is a public plan, public dollars, but going to private participating pharmacies. Can that work? Can it not work? We look at 4 countries. We look at Barbados, the Bahamas, Jamaica, Trinidad, and Tobago with their particular plans. I could have added Antigua and Barbuda with its medical benefits scheme. Also, the medical benefits scheme pays a lot more attention now to persons getting prescription drugs in their own medical benefits managed pharmacies as against in private pharmacies. Why prescription drug plans? Well, we can start with the big issue of the burden of chronic disease. We need to reduce that, and that has already been looked at. Here's the second part, which we don't often spend a lot of time on. The persons who present themselves for treatment really representing the tip of the iceberg. There's a large amount of what is called unmet need in the population, and 2 very early studies one can pick out from Jamaica and something which was done by Professor Ennis pertaining to high blood pressure in Barbados, and the data which was now presented by Dr. Mori from Belize, looking at the same kind of data. When you look at NCDs in the Caribbean, if you take, for example, 40% of those with NCDs are not even aware of the condition. 36% of those are aware, but they are not treating the condition. And 24% of the persons who have the condition are aware and treating their condition. Sorry, but in Jamaica, there was no data available, and those who are treating and fully compliant or those who are what you would call controlling the condition. I've just inserted a statistic from Professor Henner's study when he was looking at high blood pressure in Barbados, and he found that only 19% of the persons who were treating their high blood pressure were actually fully compliant. I think Dr. Maury just presented that in Belize. You're looking at compliance and control in about 29% only of diabetics and about 11% in hypertensives. So this is where the tip of the iceberg or the big gap comes in. Could drug prescription plans make a difference? Well, we all know that probably 90% or more of the NCD patients require drug therapy. You go to get a consultation, and the majority of the consultations will give you a list of items that you need to purchase. But can persons always get access, and they also always afford essential drug therapy for their condition? Well, you can go to the public sector, but this is where the big problem comes in. Public sector has several issues with the unavailability of medication. The public pharmacy may close at 3 o'clock or 4 o'clock in the afternoon. What happens to all those working persons who have chronic diseases? Public pharmacy may have stock out, so may ask you, well, we can't give you the full supply now, you have to return, and many persons do not return. That leads to access issues. That leads to problems in terms of persons being able to get access to medication and to manage their condition. And persons are often pushed into the private pharmacies to get the medication. And this is where the cost of the pharmaceuticals become very important. Put the two of them together, then you have the whole problem of access and payments, or burden of payment, that are affecting a lot of persons, which led to problems in these countries with persons treating their condition, persons being compliant. Can the prescription drugs make a difference? And we can look at these from the patient point of view. Can it reduce your burden of payment, especially if you have to? Can it improve access, especially since there are challenges with pharmacies? Can it improve your compliance? And of course, overall, for the health system as a whole, can we also get benefits from prescription drug plans? Quality of drugs. Not always we can trust the drugs which are sold in the private pharmacies, but how do we ensure that they do get quality drugs for your chronic disease patients is part of the objective of this cost-effective medication. Rather than just insisting on the higher price medication, can you also have other cost-effective medications which you use? Can access improve the whole issue of reduction in reduction in complications, reductions in hospitalization and higher costs within the health system? And of course, for the overall economy, which we've mentioned, this is part of the social safety net in many countries. You want to get medical cost control. You don't want your cost of medical care, pharmaceutical care exceeding general inflation in the country. And is this a way that you can try to hold that back? Productivity gains in the population and the whole partnership, which can bring efficiency. 4 plans which we want to look at, some of the features. Barbados plan has been around for a fairly long time, since the 19th experience. Jamaica and Trinidad and Tobago about 18 years ago, so we have a good span. Bahamas in 2010, so we do have a 10-year span. We can look at that. Are these plans legislated or not legislated? Well, except for Trinidad and Tobago, the other plans are not legislated. How are they managed? And this is a crucial part of the whole aspect of these plans. They're not all Ministry of Health dominated plans. Barbados is run by the Barbados Drug Service as a separate department of the Ministry of Health. Jamaica has a new statutory body called the Health Fund. In Trinidad and Tobago, it's jointly run with Social Security Agency, and in the Bahamas, it's part of the Social Security Agency. Diseases covered, and we'll take a look at these in my next slide. 6 and more conditions in Barbados, 17 in Jamaica, going beyond your hypertension and your diabetes. 12 conditions in Trinidad and Tobago, 16 conditions in Bahamas, I think it's about 9 or 10 in Antigua, if you look at that. And your eligibility, the entire national population. All persons who have these particular chronic diseases, in some countries, you must be registered. That's a requirement to be eligible. You have to be registered and given a membership card, like in Jamaica and in the Bahamas, in Barbados and in Trinidad and Tobago. You don't, and that can pose problems of administration. There's a listing of conditions which are covered. All of these conditions, Trinidad and Tobago, Bahamas, long list. Main design features of these programs. Where we get into the business side of where's the money coming from? In the case of Barbados, there are two main sources of money. One is the tax funds, which go to the Ministry of Health, and some which is transferred to the Barbados Drug Service. But also recently, since 2011, the Drug Service has insisted that there's going to be a dispensing fee which has to be paid by the patient. Jamaica has a diverse sources of financing. There's general taxes, but there's also a share of social security deductions, and there's also a share of special consumption taxes, which come out from tobacco sales, which come out from petroleum and from alcohol sales. So that's a diverse source. Trinidad and Tobago has a single source, taxes coming from the government. Bahamas has a single source, share of funds from the Social Security Organization. And you're going to see some little numbers which are shown on the side. Doing an informal ranking.
Dr. Walker,
yes,
sorry to interrupt you. You have to speed up. You have 3 minutes left.
Okay, good, thank you. My numbers on the side give you an idea as to whether the particular plan is close to what you're looking for as the most efficient, or it is far from that. And there are 10 key areas that we examine on the business side. Was the source of money, how the drugs are procured? Is there a defined drug formulary? Are there prescribing protocols, quantity over time limits, or open prescribing patterns? What's the provider network? Are they contracted or not? How is the database and the claims processing managed, electronic or manual? Are there co-payments or no co-payments? What is the reimbursement system like? Is there health promotion, which is part of the plan? And are there frequent audits and reviews? Just a comment on the payment terms, because the different plans have different payment terms. Barbados look at the acquisition cost of the drug. They look at the dispensing fee, and then that's how you get paid. So then the lower the cost, the higher the margin, and the higher the cost, the lower the margin. Same applies in the Bahamas. Jamaica uses a reference drug pricing system. And what is the best available drug in the marketplace? The health fund pays up to 95% of the reference price. And if your doctor prescribes something other than that reference drug, then you have to pay the difference between the and the price charged. Trinidad procures the drugs, distributes to the pharmacies, and Trinidad gives them a single fixed payment for prescribing. Different payment systems. Has availability improved? Has access improved in these countries? Yes. Has waiting times been reduced? Has the burden of payment been reduced? Yes. Do we have quality control? Yes, because all the drugs are coming from public tender from a defined formulary. Overall cost control is reasonable in most of the countries. There's a boost to efficiency when you have an electronic system in Jamaica and Bahamas, less so in Barbados and Trinidad. And of course, this is a key aspect of social protection in these countries. And we do better, optimize these plans so that they can contribute more. Well, there's more which could be done on the cost control side, especially on the Barbados side, on the Trinidad side. and particularly in the. There's more which could be done in terms of electronic data management. Trinidad and Tobago and in the in Barbados, and even in Trinidad and in the Bahamas, where we can now link up the electronic system to what we call mobile health by tapping into cell phones that persons have. We need to make sure that we have various sources rather than a single source. If you have a budget transfer only, you're likely to run. Drug plans by themselves do not solve the problem of chronic disease. That's on the prevention side. And this is what the whole matter of integrated programs, of course, the collaboration becomes very critical part for all the countries is whether we can get greater savings pooling drug procurement across the Caribbean as against each country trying. The example from the OECS countries become very clear. From PAHO Evolving Fund also become very clear. So instead of doing all of it on their own, good countries get the benefit from pooling. And then the matter of research to make sure we are getting effectiveness of the medication. There are very few studies which have used the data from these prescription drug plans to see, are these drugs effective or not? Patient compliance. Ministries of health have not been using the data to look at whether patients are compliant in utilization. Should there be incentives as to enhance patient compliance? Economic benefits to the countries, to the individuals, to the employers, to the insurance companies have not been fully examined. And we need to look at how we can make incremental changes to the plans. If we can include screening and diagnostic tests, if we can include some essential consultations, then we can have a much more rounded plan to deal with. Final slide in all of this really is that like climate change, like COVID, like economic development in the Caribbean, trying to do it on one's own is not going to be amount of efficiency, economies of scale of working together. And just because we are islands does not mean that we have to try everything ourselves. Thank you.
Thank you very much, Lanta, for that presentation and for keeping to time. Apologies again for having to interrupt you. So we will now move to the last presentation in this panel, which will be given by my friend, Ms. Rosa Sandova. And before I introduce her, I have to acknowledge Rosa and team's contribution to this seminar by collaborating with us from PAHO, as well as the collaboration from CARFA to make sure that we have this important seminar with the eminent list of speakers that we have. Thank you very much, Rosa. And so Rosa will be presenting on using fiscal policies to address NCD risk factors. Ms. Sandova has been with the Pan American Health Organization in increasingly complex roles in non-communicable diseases prevention since 2003. As advisor on tobacco control, she is responsible for leading PAHO's Technical Cooperation on Tobacco Control. She also leads the team on economics of non-communicable diseases with the objective to facilitate the generation and use of economic evidence to support policy coherence to address the NCD epidemic. Rosa holds a degree in economics from the Pontificia Universidad Católica of Peru, her home country, and a master's degree in public administration from the Maxwell School of Citizenship and Public Affairs at Syracuse University in the US. Rosa, the floor is yours, and you have 15 minutes. Thank you.
Many thanks. Thank you so much, Abdul, for that kind introduction. And thank you, ECLAC, Ms. Bárcena, for the invitation to PAHO to contribute to this session today. So as Abdul said, I'm going to be speaking about using fiscal policies, tax policies to address risk factors of NCDs. And I'm going to share my presentation now. And I'm going to put it in presentation mode. Can you see it now in presentation mode?
Not yet.
Not yet. Okay, let me try again. Okay, there you
Yes,
go.
now we're seeing it.
Okay, perfect.
Absolutely.
So let me start by saying that I'm talking about health taxes or healthy taxes. And these are excise taxes on harmful products. And specifically, I'm going to talk about excise taxes on 3 categories of products, which are tobacco products, alcoholic beverages, and sugary drinks, which are known, as my previous colleagues have mentioned before, these are products that are identified as risk factors of NCDs. And these interventions or using taxation on these categories of products have been identified as cost-effective interventions in a number of political commitments. I'm listing some there. And also there are manuals or guidelines on how to use these interventions or these policies as to contribute to health outcomes. So one of the main, what I would say, one of the beauty of working on non-communicable diseases, but also a challenge, is that for us coming from the health world, from the public health world, we're talking about interventions that are, in most cases, not in the hands of health authorities, either totally or partially. And one of them is exactly the intervention I'm talking about today, which are excise taxes, which, as we all know, are in the hands of the Ministry of Finance. So the first question, when we start talking about tax policies, the first question is, do they really work? Do they really reduce consumption of these products? And I started working on this topic in 2004, and I remember how there were still at that time people asking whether increasing taxes as to increase prices of tobacco products would indeed reduce consumption, given the addiction factor, and that people will not be able to stop consuming tobacco. And yes, of course, tobacco is very addictive, but at the same time, there is evidence now, and we prove that yes, it indeed consumption goes down in a less percentage than in the percentage to increase the price. This is what we measure through what we call price elasticity of demand, but it does go down. And I'm happy now to report that in Latin America and the Caribbean, in 2015, a systematic review was done for countries in our region, and we found that the price elasticity in our region is -0.4 long run, -0.3 short run. But what that means is that if you increase the price in 10%, the consumption is going to go down in 4% in the long run and 3% in the short run as average for the region. So we don't even need to rely anymore on global estimates. Rachel was talking a lot about how it's important to have local evidence, and this systematic review is possible because there are many national studies done in our region. So that's the case of tobacco products. Then in the case of alcohol, I do have to say that we have a gap in terms of research on alcohol demand in our region. We do have evidence from the world, and it will be important to continue strengthening the evidence that we have in our countries, in the countries of our region. But we do have, as I said, evidence from the world showing that yes, indeed, consumption of beer, wine, spirits, and as an average, all alcoholic beverages go down if you increase prices. But also you can see how it contributes to reducing alcohol dependence, on how it contributes to reducing motor vehicle crashes. So it is working from a public health perspective. And for sugar sweetened beverages, the same thing. In this case, the evidence is emergent, both at the global level and in our region. And here, very proudly, I can say that the evidence in our region is contributing a lot to the evidence at the global level. And here you have 3 cases, Mexico, Chile, and Barbados, where you do see that the impact of excise taxes on sugar sweetened beverages does contribute to decreasing consumption and purchases of these products. So first question was answered, and which means whether they are effective in reducing consumption. The answer is yes for the 3 categories of products. So now, do they generate additional revenues? And for the economists in the room, from the moment I presented price elasticities, you probably already identified that yes, they contribute to increasing revenues. But here we have, I'm presenting here a summary of a simulation of how much they can contribute in terms of tax revenues. And I would ask you to look at the last column in that table, and you will see for tobacco, for alcohol, and for SSVs. And look specifically at alcohol. alcohol. We all know that probably the impact in terms of increasing revenues from tobacco relatively would be small, but not necessary for alcohol. And I will come back to this point later in my presentation. So then, so number one, yes, they reduce consumption. Number two, they do increase revenues. Number three, are they being implemented in the Caribbean? And I'm going to focus in this question in the Caribbean specifically. And the answer is yes. The answer is yes also for Latin America. They are implemented, but they are not yet implemented in a way that they would really contribute to reduce consumption of, in this case, tobacco, for example. And they are probably not being used in a way as to take as much advantage as possible in terms of obtaining revenues. So here, what I'm showing is this is cigarette tax scorecard that was developed recently and launched this year by the University of Illinois. When they compare how countries are using tobacco taxes as a way to reduce consumption, and they evaluate the tax structures from whether they contribute to reducing affordability, whether the tax share is high enough, and what you can see there is that the Caribbean has an average score of 1.8 out of 5 points, and it's lower than the Latin American region, which scored 2.26. Still, the highest score is 5. So there's still both sub-regions are far from being at really the desired level. So all countries score below 3.5. Antigua doesn't have an excise taxes on tobacco. They have import duties and, of course, VAT. So summary, there's ample room for improvement. They are implemented, but there's ample room to look at the tax structure and adjust it as to make it contribute to health outcomes. The same case in alcoholic beverages. What you can see in that table there are all the countries that do apply excise taxes on these type of products. Again, Antigua does not apply excise taxes. And also, I'm quoting there what we keep saying about best practices and which is how they should be implemented. So it's not only whether you implement the tax, but how you're implemented it. And this is something that, because of time, I cannot go in detail. But for example, one thing to look at is that the tax is implemented based on the volume of ethanol and, for example, not in the size of the bottle, because that is misleading in terms of whether you are contributing to effectively reduce consumption of these products. And for SSVs, and here I really like to present this table because this was the work of a group of us with lots of collaborators from outside PAHO as well, in terms of identifying whether sugar-sweetened beverages are applied, whether excise taxes apply to sugar-sweetened beverages in our region. And what we found is that, yes, actually, it's a case similar to tobacco and alcohol in the sense that these taxes exist, are being implemented, but not necessarily being looked or reviewed or revised based on whether they're contributing again to health outcomes and whether we are doing the best we can. So here you can see that 6 out of 13 countries for which we collected information do have SSVs. So the policy narrative then it's important in the sense that we're not talking about introducing new taxes. Nobody wants to introduce a new tax, right? So we're not talking about introducing new taxes for most of the countries in our region. We're talking about adjusting taxes to best practices, to how they actually can be that very important intervention to reduce consumption and contribute to the onset of non-communicable diseases, because remember, we're talking about reducing consumption of products that are extremely linked to non-communicable diseases, are the main risk factors of non-communicable diseases. So do we have opportunities to work on this in the context of the pandemic? And let me get now to discuss this in the context of COVID-19. So the first photo that you see here in my screen is when we were all getting together for these meetings. This is a meeting that happened in Washington, D.C. that we PAHO hosted and on tobacco taxes specifically. And what you see there, these are colleagues from the International Monetary Fund, from the World Bank, and from the Inter-American Development Bank. And they all concluded that there's still much potential to increase tobacco taxes in countries in our region, as I have to say, it happens in most countries of the world. Then during the pandemic, we've been discussing, and there you can see Abdul and also colleagues from the World Bank and colleagues from the University of Illinois and colleagues from Ministry of Finance, as for example, a case of colleagues from Jamaica, and I think in that meeting we had Peru as well. And so the conclusion is, where's the opportunity to work on all these taxes in the context of the pandemic? And I pick some of the things that colleagues in this meeting say. So for example, COVID-19 is a big opportunity for health taxes. Linking health taxes to a wider tax reform can be very effective. So in which countries are we discussing tax reforms? And how can we discuss excise taxes under this framework? Then higher tobacco and alcohol taxes and new sugary beverages taxes will significantly reduce consumption and raise revenues. Health taxes in general will improve health outcomes, and help raise revenue, especially in the short term, could decrease health system impact of future waves. So, and of course, we all know, and we've seen today very eloquently, we heard very eloquently from so many panelists today of the link between the pandemic and non-communicable diseases. So maybe what I want to do to end my presentation, what I want to say to end my presentation is that we have in our hands a policy that is both effective and bold. And here I'm copying what one of my colleagues from the World Bank mentioned in one of our webinars. She said effective and bold. And let's just remember that excise taxes have been used in the past to address emergencies, to address earthquakes, to address the need for extra fiscal space to address natural disasters, for example, because they constitute an immediate source of tax revenue. And also another thing that I promised to come back, and I'm going to come back now, and it's the issue that sometimes when we talk about tobacco taxes specifically, and we heard, which is true, that the revenues coming from them are relatively small. And I do agree that we need to calibrate our expectations in terms of how much revenues we're going to get. But if we look at the revenues coming from tobacco and SSDs and alcohol, then these are not trivial. Then these can contribute to building back better, as we all want. And then it does not contribute only in the short term, but in the long term, there's a contribution to the financial sustainability of the health systems. We've all seen today and through the almost 2 years how health systems are being stressed by the NCD epidemic linked to the COVID-19 pandemic. So we have in our hands something that will have immediate short-term result and also a long-term one. And they are not regressive. And I will invite you to visit our websites in Economics of NCD and Health Taxes websites in PAHO, where you can find all the evidence that we've been collected on this. And with that, I just want to finish by saying that this constitutes a win-win-win-win policy. It contributes to tax revenues, can finance development, increases productivity and well-being because it prevents non-communicable diseases, contributes to the financial viability of health systems, and of course, improves health outcomes. And again, thank you so much, and looking forward to the discussion.
Thank you very much, Rosa, for that very informative and powerful presentation. That concludes the presentation from our panelists, and we will manage to, and I have to thank them for really keeping to time and helping us to have this presentation within a reasonable time period of time. Now, we will now will invite the panelists to please turn on their camera in anticipation of the discussion session. And as far as I can see, there are no comments in the chat, but there is also a smiley face icon on your screen. So if you prefer to ask your question or make your comment directly, click on that smiley face, and on top of it, you will see the virtual hand. So click on that to signify that you would like to take the floor to ask a question or make a comment. So while we wait for people to make up their mind if they want to ask a question or make a comment, so I would just like to emphasize one or two key. Okay, now we have a hand. I can't tell who it is from, but it's from Jamaica. Is that
I think, is that me, Alafia?
Oh, that's Professor Summers. Go ahead, please.
Thank you very much. Thank you for inviting me to this conference. It's been very, very interesting. I just wanted to raise a question of the political difficulty of introducing taxes at this time when persons are suffering from COVID recession, and asking whether we should take an approach that says we're going to cross-subsidize rather than say increase taxes. I think it would be more politically acceptable. So for example, maybe it is that we need to increase the price of white bread and use that money to directly subsidize to reduce the cost of 100% whole wheat bread. I think that kind of approach would increase the price of unhealthy foods, decrease the price of healthy foods directly so the consumer can see the link. And I think it might not come across as taxation as such, but rather cross-subsidy. And that might be more acceptable politically given our COVID recession situation.
Thank you so much, Professor Summers, for that question. And I'm going to ask Rosa to take note of that. Don't answer yet. Let's take a few more questions and comments, and then we'll come back to the panels. If you could lower your hand, Professor Summers.
Yes, sorry.
Oh, thank you. Okay, pending the time, we'll have additional comments or question. Let me also direct a question to Dr. Nugent, because I noticed in your presentation of the case in was it Costa Rica, where you show the burden of disease, the economic burden, which indicating the direct and indirect cost, and with the chart that you showed, with the gold and the purple, the distinction between the direct and indirect cost, I noticed that the indirect costs tend to be on a proportional level, tend to be higher percentage of the cost than the direct cost. Is this something that it's just a one-case situation for that country, or is it a trend that it's more of a characteristic thing that happens in the developing countries, or more specifically in Latin America and the Caribbean? Because I'm asking that question because typically, except those who have economic background or really involved with the economic assessment of health, the focus is always on the direct cost. How much do I have to pay? You know, what is the cost of medication? Not so much attention to the indirect cost. But if your research or the presentation, the slide that you showed, indicate or suggest that the indirect cost is actually greater than the direct cost, is that something we should be paying closer attention to when we do this kind of analysis? And so there are still no other hand up. So I'm going to ask Rosa to answer the question, and then Dr. Nugent, you can follow up. You can take the floor after Rosa.
Yeah, sure. Thank you, Abdul, and thank you, Alafia. Great question. And my answer would be check locally on what is, where you have the opportunity. So if the opportunity at the country level is to link increasing taxes on, for example, alcoholic beverages to earmarking, I would say go for it. And that is the case of what many cities and counties here in the US have done. It's a strong link, increasing taxes on sugary drinks with earmarking for example, water in schools or related actions like this. What I would say at the same time is that we need to check whether there is not support on the part of the public when there is indeed no support on the part of the public. And I would highlight that, for example, in the case of tobacco taxes in Mexico, when we implemented a poll on whether the population would support the increase in tobacco taxes, we found that even smokers supported it. So sometimes what I would say is that there is a perception on the part of policymakers that there is no support for health taxes when actually there is support from the public opinion. So I would say let's implement some polls maybe and see whether the support is there or not. And also take into account what is the perception of the position of the Minister of Finance, right? Earmarking is not necessarily something that most officials involved in tax policy would support. So again, in summary, I would say check at the local level what works, and of course, linking it with earmarking is great if it's politically viable in that specific country. Thank you, Abdul.
Thank you, Rosa. Rochelle?
Yes, thank you for the question. And you're right to note that the indirect impacts, or sometimes we call those the productivity impacts, are larger than the direct health expenditures. That is generally true across countries. It can vary, as you note, too, where, for instance, in some high-income countries like in the US, where medical expenditures are very high, then there's going to be, much more on the direct side. But then also the countervailing thing is that we measure the indirect impacts according to the lost income of those that are out of the workforce prematurely or reducing their effort in the workforce. So when incomes are higher, as in a higher income country, that will also raise the productivity measure itself. So these things are, relatively country specific, but in general, we see those productivity impacts having a bigger proportional share of the overall costs of NCDs. I would go on to say that that's really important, as you're suggesting, Abdul, because it links it to the overall economy and it links it to economic and sustainable growth and development. And in fact, when we are looking in some of these cases at a larger lifespan, when we're bringing in children or adolescents, which we do with some of the cases where they're particularly affected, then we can measure even human capital impacts. So for instance, for adolescents who may be suffering from some of the NCD risk factors, and we know that they're going to experience more disease later in life, we can show impacts on their education and then on their potential earning capabilities. So that links it to the human capital measures that the World Bank has been talking about for some years now, links it to broader societal impacts like education and the ability of people just to have broader well-being. So I think that's really key in your seminar here, is to not just think about those narrow economic impacts, but we're broadening it out when we have the data.
Thank you very much, Dr. Nugent. And it appears to me that this has been quite informative because we do not have many questions. And in the interest of time, because we have to conclude this seminar, I would like to thank all the panelists, Dr. Ennis, Dr. Nugent, Dr. Larta, and Ms. Sandova, for the presentation and for sharing with us your expertise. We've really benefited from your knowledge. So it will now be time for me to hand over back to the chair, Honorable Minister. Thank you for the opportunity. Back to you.
Thank you, and you've thanked your very excellent panel. So I think the only thing remaining for me to do is to thank you, Mr. Abdul Qadir, for your expert handling of the panel and the very rich discussion. I know that certainly as a Minister of Finance myself, we're in the midst of our budget planning for the new year, and we're having some of these same discussions, particularly on the topic that Rosa dealt with, essentially sin taxes, and on tobacco and alcohol and the like. But what certainly the evidence is showing us in our own context is that there is a point beyond which taxation in these small open economies leads to more bootlegging and attempts to circumvent import taxes at the port than they do actually reduce consumption. And then we end up having to spend more to police the ports and to stamp out the type of corruption that takes place when people are trying to get around high excise taxes. but it's certainly an area, and I agree with you that there hasn't been a great public pushback against the sin taxes, but there are some other costs involved once the price of the products get beyond a certain point. Given the time and given our scheduled closing time, I just want to thank you all for your participation in these discussions, and I will turn directly to our ECLAC Executive Secretary, Alicia Barcena, to share with us her final thoughts on this rich discussion today. Alicia?
Thank you very much, Mr. Chairman. Thank you, dear Camilo, distinguished panelists and friends. I'm sure that you will agree with me that this has been a most informative and interesting seminar. And let me join our chair, Camilo Gonzalez, in thanking our panelists, our moderators, our commentators, who made very substantive presentations with evidence-based data on the impact of non-communicable diseases on our economies, in the health systems, and in households and people. We have benefited from the knowledge and perspectives of the researchers and practitioners on the front line of managing NCDs in the subregion, experts who have been assessing both the social and economic impacts of the high prevalence on the economy and on the well-being of the Caribbean people. Most importantly, and I wish to remind what you said, dear Chairman, at the beginning, interventions on NCDs is under our reach, and which is clearly different from other problems that the Caribbean is confronting and the region is confronting, such as climate change and adaptation, things of the sort, that it depends on the global community. In this case, this panel was able to highlight which are those policy interventions that work and which is possible to act on it. And they demonstrated, by the way, that investing on primary health, on a medical scheme properly regulated, to which, for example, to reduce the burden of payment, to ensure access and availability of pharmaceuticals, on community-based programs which include prevention, particularly on nutrition, and how these investments are particularly crucial in our young populations, including schools, for example, and households. And this discussion was very meaningful in showing the linkages between health, economy, and nutrition. And I want to highlight, Chairman, if you allow me, 10 messages that I am taking away from this seminar. Number one is that COVID-19 was a wake-up call that magnified the importance of non-communicable diseases, as the majority of cases that affect the prevalence of NCDs were the most affected, and the unvaccinated, by the way. Secondly, that the NCD care treatment has been undermined somehow because of COVID. So therefore, we need to focus and to support the efforts of the health systems and the people that are around the panel today, and many others that have been making enormous efforts to close the gaps with innovations in telemedicine, in remote consultation, and the use of wearable technologies. Thirdly, we need to have an integrated approach to NCDs and to move towards what our chairman, Simon, moderator, said, a societal approach. We call this an urgent move towards a care society. This is a societal problem, not only a medical problem. So we need to go beyond the medical approach to bring in the economic sectors and to ensure the importance of fostering healthy lifestyles, prevention, and reducing NCD risk factors. We need to ensure that we are using the whole range of tools that we have in hand, including nutrition, for example, which was a very powerful linkage that one of our panelists made with the study and the survey of 8 countries in the Caribbean, where he very much demonstrated the linkages between income, nutrition, and the importance of the strong call, which is my 4th message, to return to primary health care that we need urgently, particularly for the treatment of hypertension and diabetes, and the investment in community-based programs, as well as collaborating with non-governmental organizations that are also very active in the community-based localities. 5th, I think that this seminar showed with evidence-based studies the social and economic costs and losses associated with NCDs, including the impact on the workforce with high levels of chronic illness or cost linked even to diminished productivity, but also to the inevitable increase in demand for greater cost in treatment, and which expose very much which poses a lot of burden in the income of the households. 6, the impact of the severe economic impact of COVID on incomes and the consequences in diet and nutrition, because since households had less income, they went into less nutritious food, and how governments have been trying to cope and mitigate these impacts by transfers and allocation to the households of health, and of course of in-kind support to focus on food security, nutrition sensitive social protection, and support for farmers. 7, there is a great need and urgency for equity in access to essential medicines, including reducing the waiting times, of course, the out-of-pocket payment burden. And I think that here we have a connection to something you were discussing, dear Camilo, on the dedicated taxes that can target the NCD risk factors. I agree with you that this for the Caribbean is difficult because many of these products are imported. So therefore, you are in certain way importing as well the additional burden of the taxes. But so we have to think carefully and profoundly. And I think that Rosa can help us, and ECLAC, we can certainly do our part of the work to understand that the fiscal policies in the Caribbean have a differentiated approach. We need a different approach to those, and we need, of course, international support to deal with both prevention and treatment. The 8th message I would say is that these public cost-effective interventions, I was very impressed by the data that we were shown about how much you need to invest, $1, and how many returns you get out of that, 2 or 3 times the returns from whatever you are investing. So I think this was something that was very much appreciated from my perspective. And of course, I agree with you that interventions on expenditures, this is my 9th message, interventions on expenditures to improve lifestyle can be very cost effective. I mean, and to put in motion the 16 best buys. I was very attracted to the notion of the 16 best buys and the global action plan that, by the way, was firmly supported by the Caribbean countries. I remember very well when the global action plan on NCDs was put in motion by the UN, but the Caribbean intervention was crucial for this topic. And these 16 best buys, I think, are very interesting, and we have seen cases such as Peru, Costa Rica, Jamaica, and we were presented with Barbados, with Belize, with cases that are so much interesting and that show, and Salvador was also one of the examples. So finally, Mr. Chair, and this is my final message, is that we need to expand partnerships among the institutions between, for example, PAHO. What a remarkable job of PAHO. I want to underline the remarkable job of PAHO, and we want to become a voice of PAHO ourselves, because that's why our collaboration with PAHO is so important, because we want to advocate what PAHO has been doing for all these years with such a professionalism. So we need to strengthen this relationship between ECLAC and PAHO, for example, but also with other UN institutions. Of course, with academic institutions, I want to highlight the University of West Indies. I think it was just fantastic, and the surveillance and the research, which was based on the Barbados National Registry for Chronic NCDs, I think is a great example. What we heard from CARPA, thank you so much to our colleague, which was a remarkable intervention from Joy St. John. Thank you so much for that. And of course, we need to put in motion and we need to support the instruments that exist. For example, the PAHO revolving fund and all the research that emerges from there. So I really want to thank you all, because I think This has been a fantastic experience. I want to really thank you, Diane, and the team of ECLAC, because we really want to move ahead, and we put in motion, and we want to invite you to be part of this plan for self-sufficiency and health matters in Latin America and the Caribbean. We're going to hold meetings in early December and in January and in late November on the regulatory systems, on the clinical trials, and we want the Caribbean to be part of this. And of course, PAHO, which is essential because without PAHO, we cannot do anything. So we really want to move, and we look forward to working with you and with your focal points, because I think we have in front of us a win-win proposition, as somebody said at the end of the panel. So I want to thank you so much. I learned so many things today, and I want to tell you that you count on ECLAC, and we are ready indeed to move on this direction. And I hope to see you tomorrow, dear Chairman and dear colleagues, when we start our monitoring committee. Thank you so much. Over to you.
Thank you so much, Alicia, for an excellent summary and for distilling the wealth of information that we've heard today into 10 succinct points. Thank you very much for that. And I thank all of the panelists again. I want to thank both Alicia and Diane for helping us to place once again high on the agenda of priorities the issue of non-communicable diseases. I think that it's very important, given the Caribbean's initial advocacy on this topic in 2007, their work in 2011 to make it highlighted at the level of the United Nations. I think this was really an opportune time, given the effects of the pandemic, given the challenges that we all have in economic recovery post-pandemic, to focus on health, first of all, narrowly, and then focus on ways in which we can reduce the drag that non-communicable diseases are placing on economic growth, revenue collection, productivity in our region as we seek to rebound from this very difficult period that we've had. I too hope to see you tomorrow, Alicia, at the meeting of the CDCC and all other distinguished participants. So today, our seminar is at an end on time. Congratulations to all of the moderators for that and presenters. And we'll meet tomorrow for the 20th session of the monitoring committee of the CDCC. And we'll begin promptly at 9 a.m. And I look forward to seeing you all then. So have a good afternoon. Thank you very much for your presentations, and we'll see you tomorrow. Bye-bye.